Kabaka. From 2012 to 2021, we notified 612 suspected cases. 3 turned out positive for GM. In 2023, 3 cases were confirmed in 3 districts, and after confirmation, we did a vaccination round. In November 2022, a suspected case was pointed out in Gazawa district, and from January 2023, the National Institute confirmed this case of Gazawa. In February, we now launched a focused investigation around the case. The objective was to describe the story of the case, identify the vector agents, identify the vaccination coverage, and put in place control and prevention measures. Niger is situated in West Africa. You can look at the first map with the neighboring countries, and then we have in the second map, we have the area affected in red. In 2023, we had a population of 238,605 inhabitants. We carried out a cross-national study from 10th to 17th February 2023, and we considered all the notified cases for yellow fever. We applied the definition of the guide SIM R3 of Niger. Data was collected through documentary review, interviews, active research, capture of mosquitoes, and larva capture. We did analysis of data which was carried out by Excel. In terms of results for our study, the history of the story is a boy of 16 years who had not traveled and had not been vaccinated against yellow fever, whose symptoms started in 15th November 2022, admitted to a consultation center 24th November, and the sample drawn the same day, and then 15th November treatment started. Through our entomological intervention, we were able to capture an Anopheles mosquito from Gambia with Aedes aegypti. Among the larva captured, 3 were proven positive. The study for the coverage of vaccination was within over 9 months. We had 50 households visited, 335 persons studied, with a cover of vaccination of 35.6%. So in total, we counted those who had vaccination cards and those who didn't have. In terms of discussion, Aedes aegypti was found in 33.33%, and we need to point out that the same vectors were found in the other districts where we had already identified the cases, and these districts we need to say that these have been characterized by permanent and semi-permanent cases. And we had different results. At a certain moment in Aqua, we had 59%. With vaccination, with cards, we were at this coverage already points out critical risks because WHO points out that we need to vaccinate about 60 to 80% of the population for safety. In conclusion, the case of yellow fever was pointed out in a district that had very low rate of vaccination. Aedes aegypti was identified during our vectorial study. The subject, 9 to 60 years, were vaccinated, and we recommend to improve routine vaccination. We thank the Public Health Ministry and in Niger. Thank you.
Okay. Thank you so much, Abubakar. Abubakar actually took less minutes. You saved us time, which is very good. Thank you very much. So questions for Abubakar? Yes, Angela.
Thank you, Abubakar. I just want to know whether you have this information. Do you have the coverage for yellow fever in Niger? Because you gave us the WHO recommendation, so I want to know what the gap is, the coverage vis-a-vis what the WHO recommendation is. Thank you.
Okay. Abubakar. Any? Okay. Yeah.
Bonsoir, donc je m'associe aux félicitations.
Later, Mr. Abubakar, but I'd like to understand why results were confirmed on 15 January and investigation are set to be done, were done in February.
Another question for you, Abubakar. Please take note. Oui. And then the last one there. Okay.
OK, merci. Merci à docteur pour la bonne présentation. Juste, c'est une question de compréhension. Je voudrais que de façon pratique, vous puissiez me décrire vraiment le contexte et la justification de cette enquête. Là, je n'ai pas bien compris. Merci.
Okay, last question. Okay. There is one burning one here. So, Abubakar, take note. There is a question there, then there's one here.
Okay,
yes,
thank you, Abubakar. Your very nice presentation. I want to understand about when you are conducting the methodology that you are using. You said about the larva capturing. So how you are isolating or how you are capturing the larva that you have used to collect your cases. Over to you. Thank you.
All right, thank you very much for your presentation. It's like I missed it out, or maybe you didn't mention it. What were the public actions after this study? What do you actually do with it? Public actions.
Those ones, if we have time, then we shall ask. Okay.
Merci pour vos questions.
Thank you very much for those questions. The first question sought to know the coverage. We had an idea about the vaccination coverage in the district in question. We have an idea about the administrative coverage. That is what is reported through the ministry on the data of coverage. But we needed to do a study on coverage, a very focused study on the ground, so that we have a clear idea about the actual coverage. Because we have a difference between the administratively declared level of coverage and the actual one. So at the time we looked at the data, that was around 70%. But you noted that on the ground, those who have the vaccination documentations or cards are just about 57%. The second question was to know why there was a delay between case notification and the confirmation. Actually, that is the common case for notification of yellow fever cases. In our country, we do research. We have a national reference lab which doesn't do the PCR test. So it is after the blood test that we can see whether it is positive, and we can send that to the Institute of Dakar for confirmation. That is why it took that lapse in time. Another person sought to know the basis of the study. We are talking of confirmed cases or a confirmed case. If you looked at my presentation, I talked a lot about notified cases. But if symptoms are manifested, there is need to do a detailed inquiry on the ground in order to respond and fight in a more focused manner. So this study was to identify the vector. We did studies to identify the vector, and that was the main motivation. There's also another question that sought to know how we actually collected the larva. We go out as a multidisciplinary group. It's a One Health team. We have entomologists with us, and they are the ones who understand the technique. They are the ones who undertake that part of capturing the larva. The last question sought to know the actions that were undertaken after investigation. In my conclusion, I pointed out that during the investigation, because we were meant to go and investigate, one of the objectives of our investigation was to put in place control and prevention measures. One of the key activities that we undertook during the investigation was vaccination or control through vaccination. So we carried out vaccination, which was one of the critical actions that were taken after the investigation. But we also took advantage of the investigation to sensitize the community on the disease and enhance local surveillance systems at the district level, at the health structures, centers that we visited. Thank you. I hope to have answered all your questions.
So our next presenter is Evariste, investigation of Crimean Congo hemorrhagic fever in Senegal.
Good afternoon. I am happy to present investigation of the hemorrhagic fever in Congo 2022. This is the outline for my presentation. I will introduce the subject and talk about the methods used. Then we'll go to the results and discuss a little bit why these are the results before concluding and proposing recommendations. We need to start by saying that from Natalia et al. 2022, the hemorrhagic fever is in Congo. It is a virus-caused fever, and it poses a lot of public health risk and has economic impacts on the economy, because when we have this disease, the country is affected. You can no longer export meat, and we have livestock experts and public health experts, as well as economists. This work that was carried out in West Africa, we have a high level of prevalence. And in Mali, we had 66%. In Mali, we had, in Senegal, we had 57%. This is showing that this disease is really coming up. It is a priority disease in Senegal. That is why a lot of strategies have been put forward. We have a communication plan. We also have tests as laboratories. In spite of that, in 2022, we had an epidemic that killed 2 women, and this is critical cases. We had vectors. We had a positivity rate that was very high. We can now talk about the disease. So it's about, as you can see on the photo here, and actually it's a disease that is spread by ticks, which bite, and These ticks, we have the larva stage, and it takes 4 days, and this shows the characteristics of the transmission, because an animal that moves 5 kilometers can drop a tick that in an area that is not infected, and that spreads that. So this larva prefers mammals, and the ticks themselves now target bigger mammals, and then the man is affected by the use of infected products. In Senegal, we had FAO that supported a study, and you can see in red we have a zone that is a high-risk area. The problem that we have is that we do not have the critical factors of the hemorrhagic fever. We want to know the factors that would express or explain the spread of this fever. To answer this research question, the hypothesis is that to describe the profile of this fever, hemorrhagic fever, would lead to critical discoveries, and we needed to describe the profile of the disease. The study, as you can see, happened in Senegal, which is a West African country, in the north of Senegal, in the Podo region, where there are pastoral communities. We have 2 neighboring countries on the northern part, and we have rice. This is really a zone of refuge for animals from different regions. You understand why the interaction and reproduction of the ticks is high. We have hospitals, we have health centers, we have veterinary areas which are in this area. We carried out a study of observed cases in running from the 1st May to 31st October 2022 in a number of villages, which are villages in the area of Podo, inhabited by pastoralists. And the cases were collected by random sampling with we describe a pastoral unit as a collection of pastoralists within various households within an area, and the study carried out between the 1st of May to 31st October 2022. All animals identified as positive in a pastoral area in Podo enabled us to identify specific cases of viruses, and that we carried out PCR, and we had and some animals testing negative in the area. We had sheets that enable us to describe the cases, the age, the sex of the animal, and before that we pre-tested at Dagana. We trained research people, and the data was collected by Excel and analyzed. The proportions were tested by the Kidder-Fisher test, and this helped us to measure other ratios of the explanatory variables. We had an alpha risk of 5%, and the result was significant at it was significant at 0.05% or 1%. We therefore had the sheets that were filled, and we explained why the research was done and the permission was granted. This methodology enabled us to get results through the inquiry. The first results were descriptive results, which are related to epidemiological profile. So we see that we have the livestock that was contaminated or infected. We had the bracket or age of 24 months for camels and donkeys. This is the map, as you can see, where we see that the Wallo region in the north, it is a dry area, as I mentioned, where we have a lot of agribusiness, and it's a humid area with a river. And this is an area where we have a lot of pastures, and it is highly infested. Results showed that there was a significant increase in the number of cases among livestock. And for the issue of the age, we didn't have a variability that is key. In terms of the sex, we had a higher number of females than males. We also noted that animals that are zero-grazed have less chances of getting the disease compared to the animals that were feeding freely. The animals that were zero-grazed have less chances of contacting the disease compared to those that were feeding freely. The livestock farmers that participated indicated that vaccination was a critical factor. The farmers who regularly clean those areas constituted a protection factor, and the farming areas which are humid was a susceptible area for the disease. The farms where we had a lot of these results have elicited a lot of discussions. Since we also had a similar study in 2021 that identified a similarity of 47%. The farmers prefer small ruminants because they are a little more resistant. So the female are more susceptible because of the reason that the farmers prefer spreading the male, because once the ticks attack the male, they are spread more easily. With regard to the age, this is due to seasons, and so generally we can say that the herds that were vaccinated were least likely to be infected. Thank you very much for your keen attention, and we can point out that for the recommendations is cleaning and spraying. We sprayed 3,000 animals, and we sensitized farmers. Thank you.
Any questions for Jean? Yeah, now, please be advised that we have people online. So when you're asking the question, stand up and look straight to your microphone and talk loud.
Thank you for your good presentation. I have 3 questions. First one, what is the control measurement to minimize disease or to take action? Also, is there a system to capture data in this country, including hemorrhagic fever? And also how they collaborate.
Please hold. Go back. Wait for him. Wait for him.
Okay, thank you.
Yeah. Start.
First question is, what is the control measurement to take action of this disease in hemorrhagic fever? Also, is there a system that captures or collection data in the disease, including hemorrhagic fever? And also, this disease, I think, is multiple stakeholders, including One Health. How they collaborate? Thank you.
Jill, you got the questions? You got all of them? Yes. Okay. Any other additional questions? Okay, this is another one there.
Bonsoir. Tout d'abord, je félicite le présentateur de la qualité de sa présentation. J'aimerais savoir les informations qu'il a.
I really like the information that he shared in relation to the hemorrhagic fever of Crimea, Congo, particularly in Mauritania. And it was good to understand the origin of this information and the date of the study and what are the authors of this study, particularly for the Mauritania case, because you talked about the spread about of 67%, but in Mauritania we have other figures less important than that.
Okay, Jean, you can respond to those 4 questions.
Merci, monsieur le modérateur. Donc, je vais donc commencer par la première question. Est-ce qu'il y a des données qui sont collectées pour la maladie?
Question on data collected and collaborations. On collaborations, this is work that we, as I said, it's involved a lot of actors, health, environment, and also economic players. So we also have an institute that has been put in place through the National Prime Minister's Office. So the One Health Committee is the most active in Senegal, and this is work that was done involving other players and actors. With regard to data, this hemorrhagic fever, Congo fever, is bringing together the human health and animal health players, and we also had human and animal cases that were confirmed. With regard to the data, I can give you the references. This work really was based on the national laboratory figures, and it is work that was done by Nazayan in Mauritania on livestock. So I can give you the references to confirm some of the figures that are contested.
A round of applause for Jean. Now, our last presenter for this afternoon is Hussein, and he's going to present on investigation of dengue fever in Djibouti. Hussein?
Or health statistician on the Public Health Institute. I am a holder of FEDB. I will present to you the study titled Investigation of the Dengue fever in district in Djibouti in November 2021. To begin with, this is the outline that I'll adhere to for the presentation. We will first of all do an introduction of the topic, then the methods used, as well as the results attained through the study before recommendations. Dengue fever is a viral disease transmitted to men by mosquito bites. That is the Aedes aegypti. On 14th November 2021, we had 18 cases that were notified for dengue fever. On the 19th November, we carried out an investigation to determine the extent of dengue fever and put in place prevention and control measures. particularly to confirm the outbreak, to characterize the health phenomenon in places and with persons, and propose appropriate actions. So this study was carried out in Djibouti, which is situated in Africa, East Africa, with a coverage of 23 square kilometers, with a population of 1 million. This, we have 6 regions. We have Dikil region, which is the study area, situated in south east of Djibouti, with a population of 110,000 inhabitants, and with 10 hospitals or health centers, and it shares a border with Ethiopia. We carried out a descriptive study, which is cross-sectional, from the 19th to the 21st November 2021 for all the dengue cases in the town of Dikil from the 1st October to the 21st of November 2021. We collected data from through documentary review, interviews, observation, as well as research through research sheets. We used operational definition of cases as the suspected dengue cases include on all the people living in the Dikil region with a fever with the following symptoms: pain, headache, and the confirmed cases, the suspected cases confirmed through a TDR positive test, or having an epidemiological link with a confirmed case. This, in terms of methods, we used a diagnostic test, a rapid diagnostic test, to confirm the cases. And then we had the data collected, which were analyzed through Excel software to calculate the frequencies, the proportions, the median, the rate and ratio, which were calculated. The results are as follows. In total, the suspected cases were 1,271, among them men highest at 56%, with a ratio of women of 1 to 3. The age bracket highly represented was between 20 to 29 years. For the confirmed cases, among the collected cases, we had 73 tests that were carried out, from which 28 cases were confirmed positive through the dengue test, TDR test. Here we can see a graph showing the curve of the dengue in October 2021 up to November 2021. Every day we had notifications for cases. The first case was the red graph represents the cases that were confirmed to be positive. So the key clinical signs were 96% were fever. Fever dominated, and then we had onthalgia that followed, and cough. And then to conclude, the investigation allowed us to confirm the dengue epidemic in the Dikil district. And then we also had adults who were the most affected by dengue. We recommended to the Ministry of Health to enhance surveillance, epidemiological surveillance, and also we asked that the TDR for dengue be enhanced with the antigen NS1. We also undertook some public health actions. That is, all the cases were were treated. We also had case investigation, and we sought to find active cases in the community. We also had entomological research and the spraying on surfaces. So we thank the Ministry of Health, the National Institute for Public Health in Djibouti, as well as the coordination by the AFENET, and the mentors. Thank you very much for your kind attention.
Thank you so much, Hussein, for keeping time. So, questions for Hussein? Okay, yeah. Where is the mic? So as we said, please stand up and then you talk straight in the mic and talk loud. There are people online. Okay, hands up again so that we see those who are going to ask questions. 1, 2, 3, 4. Is none decided? Okay, 5, right? Okay, let's start from behind, then we end up with Angela in front here.
Okay, merci au présentateur.
Thank you very much to the presenter. I'm Dr. Bamu. I'm a doctor, epidemiologist from Guinea. Thank you for your presentation. I would like to understand, being at your public health institute, and the confirmed cases are in a certain area of the country. How did you get that information so that you could launch the investigation? And a second one, this is just a comment, because you talked about the confirmed case and the suspected case, but we cannot understand the period. When did you collect the data? So, and how did you search for the cases? Because I did not understood your methodology, and to be able to understand your analysis. Then if I look at the epidemiological curve, what we've seen, the contamination, is it between humans, or maybe you thought what has really happened, so that we can understand that curve? Thank you very much.
There, before we come to the ladies. Yeah.
Thank you so much. I'm Thomas Dugan, WTP resident, South Sudan. Presenter, we presented very well, but in your results, we have not seen any fatality rate, case fatality rate. Was there any death during the investigation? Or thank you.
Okay, ladies, there are 2 ladies. Both of you are going to ask, right? Okay, that's fine.
Thank you, Abdullah, for the great presentation. I just have a very quick question. My question is, as we know, dengue virus have 4 serotypes. So which serotype was in your investigation? Thank you.
Okay, next one.
Thank you so much, Abdullah. My question actually is, when you were presenting your symptoms, you said 96% of your patients had a fever. And we know that dengue, we identify and clarify anyone who have a fever more than 38. So some of your cases did not have fever. How did you clarify those ones? Thank you.
Okay, then you can now bring it in front here. There's another one.
One question. OK, merci. En fait, ma question, c'est, j'ai vu une recommandation qui porte sur la dotation en test de diagnostic rapide de dengue. Est-ce que ça veut dire que pratiquement il y a eu une rupture?
Rapid tests for the dengue, because sometimes we don't have enough equipment during an outbreak. So sometimes at the beginning you'll have a negative test. Is it negative, or in fact tests were not undertaken? Thank you.
Okay. Angela.
Thank you very much, Abdallah. I have one question. You mentioned that you used documents to get data from there. So what kind of data did you extract from the documents that you used? Thank you.
Proceed, Abdallah.
Donc, merci. Je vais répondre. Déjà, au niveau de l'information, comment l'information a été
to how the information was scaled up to our institute. Our National Health Institute has a department that deals with epidemiologic surveillance of diseases. So every week, we have information that is scaled up to the central level. Every week, we have information on the country, on the status of the country. So the 14th November, we had an increase in the dengue cases, and that called on us to carry out investigations in this region. For the second case, on case definition, we specified the period for the cases as the period of the 1st October to the 21st November 2021. So the research methods that were used, we carried out analysis or document analysis. We also looked at cases that existed in our health records, and we had cases that we found out, and those are the cases that presented themselves as we investigated. So these cases are those that were recorded in the Dikil region at the Medical Health Center from the 1st October up to 21st of November 2021. With regard to the mortality rate, we looked out to see whether there were any deaths, but up to now, we haven't captured a case of death in Djibouti out of dengue fever. The clinical signs which we used were cases of temperature higher than 38 degrees and cases that had temperature of 38 plus degrees Celsius. Then with regard to why did we talk of dengue? We wanted to search for the antigen. We did not have a shortage of these reagents at the center, but we had the rapid test that determined the antibody, IgG-EM, and there we preferred to look for the antigen, and that is why we recommended that we need to really have these tests. The data was collected through document review, that is health records. So that is how I responded to that question. Thank you very much.
Hussein, I think that brings us to the end. Now, Senior Hussein, you want to wrap up? 30 seconds. You have a microphone there? Give him 30 seconds.
Okay, thanks a lot. Just for more clarification for dengue fever, this is just an outbreak. This is just a first study. Secondly, we can just need to highlight. We are making those types was type 3. And we are making genotypage for all of data. Just a very important that you see. Thanks.
Thank you. Thank you so much for that clarification. So thank you so much, all the participants who are online, and then all of us who have been patiently listening. And the discussion shows that we have been really very attentive, and we followed everything. So thank you very, very much. So, and of course, thanks to all our technicians, the interpreters, that have made this very possible. So let's thank our presenters. All of them did a great job, right? Yeah. Thank you so much, all our presenters, and of course, thanks the evaluators and our note takers as well. So we've come to the end of this session. I know we've tried so much to keep time. Time is really not our best ally today, but we've really tried. So maybe we stretch our legs as we wait for the next session. For those who are going to be in this room, we are not going to waste a lot of time. We shall transition straight away, but let's stretch our legs as we wait for the chair the next year. Thank you very much. prends la parole au nom du professeur Nicolas Méda, qui est le modérateur en fait de la session. Donc, nous allons modérer cette session qui concerne la présentation de posters. Est-ce que à l'arrière ils m'entendent? Ceux qui ont besoin de traduction.
Mass media. So I think we have good translation. Is that okay?
You hear me? Traduction. Hein? Non, je suis francophone.
That will be all right.
They take questions, so I'll be able to fill this. Because once we submit, we can't. So after each person, we'll take the response and then
you can
follow them as it is.
Okay. And after questions,
and answers, so now go to the next presenter. We're done with the next presenter, the third presenter, the fourth presenter.
If we finish,
yes.
We take questions.
Yes.
And you give response?
Or we give response?
Yes.
After we give response, then we are done.
Okay. After presentation, we have to take some questions, and evaluator can work on the file, and the presenter can give a response, and we move to next presentation. Sheikh Zeni Abd El Jalil, you have 5 minutes.
Analyse de
That analysis of surveillance of the Rift Valley fever in Mauritania. This is a public health issue in Mauritania and in sub-Saharan Africa. Mauritania is a West African country with a population of 350,000 inhabitants. We have 8 regions and 57 districts. So in related to the methodology, we did a transversal study of the Rift Valley fever in Mauritania from 2011 to 2021. In terms of results, we got 308 suspected cases and 42 positive, let's say, confirmed cases. Those are the results representing those cases.
The first figure shows that 2021 has the peak, and this number of cases is explained by the issue that the epidemic hit Sabah and Brakla, and also the age bracket. The most affected is between 20 and 40 years, and that is explained by the fact that this age group is in direct contact with animals in Mauritania. The third figure, which talks about the regions that are the most affected, the most affected region is the region of Taga. And in 2020, we had an epidemic in Mauritania, the Rift Valley fever, and this is the region that they had the highest number, in which case from 2011 to 2021, it was 50 cases in this area, followed by the Wilaya Sabah, and then we have Bracken. These are the three most affected areas in Mauritania. In conclusion, our study showed that the hemorrhagic form of the Rift Valley fever has very high mortality, and this is controlled by the fight against the vectors and non-consumption of products from these animals. And then we also have the third step, which is vaccination of the animals. As recommendation, we identified, or we made some recommendations, especially at the central level as well as the border levels. When we talk of the central region, we had two types of recommendation. That is strengthen data collection systems on the ground. That is avail the necessary tools for data collection, as well as the necessary training and the people at the operational level, and also guarantee for periodic follow-up. When we talk of periodic follow-up, we are talking of supervision at three levels. That is at the central level, as well as the intermediary and operational level through the health centers. At the peripheral levels, we recommended notification and doing tests in the area suspected of the Rift Valley fever. In Mauritania 2021, after the training for health workers, we did that. Then we also have to encourage filling notification sheets. We need to train the people on the ground, and in the training of health workers, we have done a lot in this area. These are some photos. The first one is the DRS of Taga, in the region the most affected, and then we have the other region. Thank you. Thank you very much. We will now get the questions from the floor.
OK. Alors, nous pouvons passer aux questions.
You can ask questions, yes. Thank you very much. I'm Dr. Mbongo from Gabon, physician, epidemiologist. Thank you very much, and congratulations for your presentation. I had a small question. You talked about a retrospective study, a transversal one, but I didn't see in the methodology how you processed in order to get those results. Thank you.
Merci beaucoup. Je félicite le...
Thank you very much. I'll congratulate him. I just have one question. In terms of the suspected case that he found in the database, and why he didn't represent them by week the way he did for the confirmed cases. Thank you. Any other question? Thank you very much for your question. For the first one, the methodology, I did not have enough time because I had to present in 5 minutes. What we did, it's the maintain a sort of document review, but with that why I could not go in details. For the second question, we presented the result of the confirmed cases, and in fact we identified all the confirmed cases. Thank you. So I think for me, I just want to suggest to you to look at measures that you proposed for public health in terms of registration of data, because this is more of people on the ground, the work for people in the field to do, and also bring in input to enable people to do the work. I think that is okay. Thank you. The next one is Denis Okethwangu. I hope to have well pronounced his name.
His PowerPoint is posted on early evaluation of the alert system used during response to the Sudan Ebola virus outbreak, Mubende district, Uganda. Is it in this room? Mr. Denis
in the same time.
We are in this session. For us, we were here. You see in the room of session.
Room 2 is here. Denis n'est pas là, hein?
It appears Dennis is not there, so we go to the next presentation. The assessors.
We are moving to Hassan Swarai presentation. Il va présenter sur...
He'll be making a presentation
Bo district, Sierra Leone, February. You can start if you are okay. Isma Abdullahi, no.
As we follow through that, Tierno Basiru will be preparing to make his presentation.
Ladies and gentlemen, Thank you, Mr. Chair. I'm sorry, I'm not Hassan Swari. I'm Rahim Rexen Gambai representing Hassan Swari. Unfortunately, he's not here. I'm Rahim Rexen Gambai from Sierra Leone, FETP Light Cohort 1 graduate. I'm here this afternoon or this evening to present on high fatality of Lassa fever outbreak, Bode Strait, Sierra Leone, February 2023. Lassa fever, we all know, is an endemic in West Africa with an estimated 100,000 to 300,000 infections and 5,000 deaths annually. In Sierra Leone, the Lassa fever case fatality rate among the general population, specifically in Kenema district, is approximately 70%. On January 31st, the Bode District Surveillance team received a notification in the community about deaths suspected of Lassa. The field epidemiology training program trainees were deployed to confirm the diagnosis, assess the magnitude, and identify possible infection transmission routes. The methods. We adopted a modified the Lassa fever surveillance case definition for the integrated disease surveillance and response IDSR technical guideline. We collected demographic, clinical, and exposure data through interviews, observations, and review of records. Blood samples were collected and sent for laboratory confirmation. We conducted environmental assessments and active case search in the affected communities and health facilities. 30 contacts were enlisted and monitored for a period of 21 days. Our result. We found out that from January 1st to February 10th, 2023, 2 probable cases and 6 suspected cases of Lassa fever were recorded. The 2 probable cases, aged 10 and 24, died unreported on the 25 and 26 respectively. Of the 6 suspected, 2 tested positive for Lassa fever antigen and both died. The case fatality was 100%. All cases, both confirmed and probable, lived in the same house. No additional cases were identified, and none of the contact line listed developed the symptoms of Lassa fever. With these results, ladies and gentlemen, we are able to conclude that Lassa fever outbreak was confirmed with a high case fatality rate in Bode. Late case detection might have contributed to the high case fatality. Case patients might have been infected from contamination by rodent droppings. Our public health actions. We sensitize clinicians on early diagnosis of Lassa fever and raise awareness among communities affected to keep homes clean and store meals in rodent-proof containers. On behalf of the team, we want to acknowledge the following. Thank you.
Okay. Questions? Oui. On peut commencer par là. Microphone.
Oui, je me nomme Dr Vokbolama, médecin venant de la République de Guinée. Durant le suivi de cette épidémie ou pandémie, ce que vous avez géré, est-ce que vous avez le réservoir de cette source?
OK. Merci au candidat. Voilà. Bon, je voudrais juste poser une question. La Sierra Leone faisant frontière à la Guinée, de la partie Gekedou, où il y a souvent des cas de Lassa, parmi vos actions entreprises, est-ce que vous avez pensé à un renforcement de surveillance?
Did you think of enhancing cross-border surveillance on the border shared with Guinea? Thank you. Thank you. This is a very good study. I just want to build on what my predecessor said, because I noted that the actions go a lot into sensitization, but we had actions that were proposed regarding improvement of the early warning and control measures, because the rate is quite high.
I think my question will follow a little bit the question of the person who asked question before. How long have you taken to detect this outbreak? I understand that the case fatality rate is 100%. That means the outbreak has been detected late, on my understanding. What are you doing now to prevent late detection for the future outbreak? Thank you.
C'est bon? Oui.
Is that okay? Please, just to the back. Thank you to the presenter. I'm from CDC Surveillance Office in Guinea. If I remember well, Sierra Leone organized a review of Lassa, and we had a control plan for Lassa. But these actions of public health have not been mentioned, yet they are very key, where the death rate or mortality rate is 100%. Fine. So let us now invite the speaker to respond to the questions.
All right, thank you very much. Your questions are well taken care of. So the first question, you're asking for the point of contamination or the reservoir. Sierra Leone is not provided with the laboratory in order to ascertain the cause of that the virus, which means the Tolan team based in Kenema district, who are responsible to come out with a confirmation, had a team deployed at the Dambala. They were there for some days, collected sample, and it was sent. And as we talk of, as I'm talking now, that result has not been sent. So that's why we say might. That's why in my presentation I said it might have been caused. Okay. The cross-border, yes. Well, the topography of the district I'm talking of, we know we do share border with Guinea and other places, but we are not close to that border you're talking of. For those in areas where they have the crossing borders, they do institute preventive measures. So for this one, we know this outbreak might have been caused from perhaps the place where we're staying or somebody in flux with it. So that is it. Clinicians, yes. In my presentation, one of the possible public health recommendations that I made was sensitization of clinicians so that they will let them be using the case guide in order to guide them. Because like one of the question came in, late detection. So we found out that, and I even said it there, that it was due to late detection that made this case fatality to be high. So we want them now to be using the clinical guide to guide them so that they will see the symptoms. Because we know most of these viral hemorrhagic fevers sometimes come in asymptomatic cases. But if you have the guide, it will guide you in order not to miss out cases and then save life. What to do to prevent further outbreak? I think that is what in my public health recommendation. For clinicians, staff, the community, to be using the control measures that we have set. For clinicians, we say let them be using their case guide, because it is a Bible for health workers. So when you use it, it guides you to, it narrows your diagnosis. So I think that is what the last one was just a recommendation. I don't think it is a question. Thank you.
Ok, d'accord, merci bien. Voilà. Je pense que nous allons passer à la... Oh, sorry.
This, please.
Tcherno Bassirou, oui, peut y aller.
Tierno.
Bisma Abdoulaye. Ok, vous préparez, c'est bon. Patientez.
Bisma Abdoulaye, get ready. Tierno Bassirou will take over now.
Tcherno, on peut y aller.
Je suis très heureux de vous présenter le résultat de notre enquête portant sur la séroprévalence de la maladie à virus Marburg en Guinée.
The Marburg disease virus in Guinea. This is a very dangerous disease where death level is about 90%, and we don't have treatment or vaccine for this disease. Several studies have shown zero prevalence, or about 2%, and this led us to several questions that has inspired the following of the contact, and we did not identify new cases. What is the zero prevalence of this disease? What are the associated factors? And what are the knowledge and attitudes of the population with regard to this disease? To answer these questions, we carried out an analytical studies, which is cross-sectional, across populations of 15 years and above. We had two samples. The first one was to select the groups and then the clusters, and then we selected individuals within the clusters. Then we had 2011 respondents, and we collected this data from these individuals as the lab of Kikidu and Conakry for analysis. With regard to the variable knowledge and attitudes, we had weak, middle, and high, positive and negative for attitude, and poor or good for practices. And we used the PN4 software for analysis. With regard to our results, 900, that is 9, were positive at 0.4%. Assessment of the level of knowledge and attitudes for the community, we noted that 92% of the population had knowledge, poor knowledge with regard to this disease, and 34% had a negative attitude to this disease. And the assessment in terms of the health workers, 80% had poor practices. With regard to the link between this information and the disease, we noted that miners and hunters had higher chances of picking this disease than other professions. It was the same with regard to the relationship between visits to so those who visited. Then we also assessed the relationship between consumption of wild meat. Those who had consumed wild meat had higher chances of developing this fever compared to those who had not. In conclusion, we note that this disease is weak, and the zero prevalence was the rate of prevalence was higher. We also carried out public health actions. We drafted an integrated communication plan that targeted sensitization of the community and community leaders within the community. So these we had 700 sensitization sittings across the community, and we also had a number of sensitization campaigns via local radio. And this had a very significant impact because it enabled us to actually increase the notification of these hemorrhagic fever cases. And following these study, we had 600 notifications as compared to 6 cases earlier notified, and this really improved the level of sensitization in the community, and the communities themselves are now calling us so that people can be tested before burials. So we think that our actions had a very important impact. Thank you. Thank you very much. We'll take just one question. We have somebody who hasn't asked a question. Thank you very much, Session Chair. I also thank the presenter for the enriching presentation and the originality of the work. This brings me to ask him a question looking at the very interesting results of this study and the case of Marburg with the contacts that never picked the disease. Could he explain to us how they practically went about data collection on the ground? Thank you. I hope he'll not come back to summarize the study again. The second question. You want to ask a question? Yes, please take the mic.
Yeah, thank you very much. I just wanted to know, because you mentioned that in your study, the prevalence, the incidence of the disease, Marburg, was very low, and then the prevalence was high. So I was a bit confused, given that Marburg is highly infectious and has a high case fatality rate and mortality rate, so it wouldn't have a high prevalence in the population, rather. Thank you.
Okay. Bon, allez-y, vous allez répondre.
Please answer the two questions. Thanks. I will start with the first question that talked about how we practically underwent data collection on the ground. This study was done within the training on field epidemiological training. After drafting of the protocol and its testing, we went to the field where we already had the basis. We had already selected 38 clusters to be investigated, and we had not had the individuals. We went to the exhaustive numbering of the households and people who are aged above 15 years. After that data basis collection, we now went to pick the specific target persons. So we came with the participant, and from that point, we explained to them the importance of this study and their acceptance. And because we needed to give a questionnaire and do a sample. So for all those who accepted, we picked the sample. And the sample, as I explained, we took about 7 to 20 milliliters. For people who are below 15, we took 10 milliliters. And for the others, we took 20 milliliters of the blood. So this data was compiled, as I said. The analyses were done at 2 levels. That was done at the hemorrhagic fever lab in Conakry, and for confirmation, these samples were sent as well to Atlanta in the US for confirmation. So that is concretely how we went about the study. For the last question, as I said a while ago, it's the zero prevalence that I mentioned, which was at around 2%. I think it was not as high as that, but in related studies that we found, we had studies that reported zero prevalence rates around 2%. When we carried out our study, we found a general zero prevalence, which was 0.4%. But when we did a disaggregation around that, we found out that among the 4 confirmed cases, the zero prevalence was high in the village of the confirmed case, which was 36%. We will see within the work that in the village of the confirmed case, it was 1.6%, yet the general zero prevalence was 0.4%. So I was talking in terms of with relation to that. I hope to have responded to your question appropriately. I think that is sufficient. The assessors, is that okay? That's fine. Thank you very much, Mr. Tiemo. So, Bisma Abdullahi Malin. Sylvia Ayebari, kindly be preparing.
Assalamu alaikum. Good afternoon, ladies and gentlemen. I'm Bisma Ali, and I can say proudly that I'm one of the AVTB frontline graduates in Somalia. I'm currently working with the National Institute of Health Somalia, Department of Public Health Emergency Operations Center. Actually, I'm very thrilled today to give this opportunity to share my findings about dengue fever outbreak Hemorrhagic district, Mogadishu, Somalia. So to continue, as you're all familiar with, dengue is a mosquito-borne disease, and it's prevalent in warm tropical, subtropical countries. But in Somalia, actually decades of a civil war and absence of, the functioning health system, the first time this disease was reported. So is it okay, my voice? Are you guys hearing me? Okay. So the first time this disease was reported in Somalia was 2011 among some members of African Union Mission, AMISON, the peacekeepers in Mogadishu, Somalia, where 82% of their... Can you see, or you guys want to zoom in? Zoom in. Okay. So what happened the first time this disease was reported from, among some members of African Union, the peacekeepers in Somalia, where 82% of their samples were actually positive for dengue virus. And the second time, it was 2013, and the recent one, the last one was 2022, which actually this study will be focused on. Of dengue NSA1 antigen in blood samples. So if I proceed the results actually we confirmed 6 cases of dengue fever out of 81 suspected dengue fever, which and actually as you can see below the table, you can see that Somali females were more disproportionately affected the dengue compared to the males. To continue, in the symptom-wise, fever were actually the most common symptoms, followed by malaria. And also, this study is, okay. the study also revealed that the IDP camp residents were the most affected people. Okay, to continue with the recommendations, the study actually recommended that the conclusion actually we detected and confirmed dengue fever outbreak in Hemorrhagic, Mogadishu city. And the recommendation, the study actually is recommending that strengthening the surveillance system and at the same time, implementing a targeted factor control measures to reduce the mosquito. And when we look at in the context of, Africa, we can recommend for enhancing the laboratory at the same time controlling the mosquito breeding sites. Then it can be, this could be a preventive ways that we can control and contain the disease. So here, you can see here, this is me wearing the AFENET jacket and giving health education and community awareness people who live the Hemorrhagic district. So thank you so much. I just want to say congratulations, I want to actually say thank you for CDC, AFENET, for giving us this wonderful opportunity to share and gather the knowledge. Also, I can see here some of my mentors, Dr. Ellen and Dr. Qasim. Thank you for your guidance. Thank you so much. I'm also thanking National Institute of Health Somalia, actually FETB office, they're hosting in Somalia. I want to say thank you. Thank you, the director of National Institute of Health. Thank you all. Let's all unite health for all Africa.
Ok, merci. Alors, merci Malia Maline pour votre présentation. 2 questions rapidement. Oui, le voisin. Yes.
Thank you very much, Reginald Machaba Howe from Zimbabwe. One recommendation we heard earlier on in the plenary session that Somalia was pleading for support and help from your mentor, and it's good to see that the mentees are presenting excellent presentations, so commendation. But secondly, just to ask, the recommendations that you have made, have they been implemented, and who's following up on that? Thank you.
Deuxième question. Oui, allez-y.
Come.
Merci.
Thank you very much. Congratulations, because this is a very enriching presentation. Thank you for the courage and thank you for the quality of your presentation. You talked about congratulations for the presentation, which is very good, and the quality thereof is very good. You, in your conclusion, you said it's the displaced persons camp that was highly affected. The recommendations, what was done with regard to that particular camp for the displaced persons? Thank you. I just wish to propose to you to see the distribution by age, because from the study, if you present that way, there are details that you'll miss out on, especially from the literature. In the study, we have a number of areas that are highly affected. So, would you please take care of that?
Age group. Yes. Okay. You can give us a response for your questions.
Okay, let me. Thank you again for this question.
Merci beaucoup pour vos
The first
questions.
question, actually, the recommendations that actually we were given in the study were they implemented? Some of them, yes. Some of them, no. That's why we put it here. Some of the things that actually was implemented were, we recommended the Ministry of Health to do, to control the mosquito spreading sites of the country. So they did actions for spraying mosquito sites, in areas for where they were actually most affected. And the second thing is you asked what was done since the most affected people were the people residing in the IDBs. So the thing is, you're right, this study suggesting that the most affected people were the people who live the IDBs, and so many things were done, and we didn't do so much. But one of the things we have done, as I said, the mosquito breeding sites we did the spraying, we did also some campaigns for education and also health awareness that they can protect themselves, how they can protect themselves. And we know that mosquito is a day feeder. So it bites people, it's very active in the morning and until afternoon, late afternoon. So we did some campaigns, spraying, and that's all what we did. And the other thing of the age group is already present in here. So since the time was limited, I didn't much clarify. But in our study, it's suggesting that the age 15 and above were the most affected age group in this study. Thank you so much.
OK, merci bien, merci. Félicitations, Bisma Mali. Alors, Sylvia, you have a floor. Sadio Ibrahim, OK. Thank you. Ça va aller. You have 5 minutes.
Evare, biostatistician, frontline FETP, and presenting improving timeliness and completeness of reporting of weekly surveillance data, Bara District, Uganda, for the weeks of 22 to 34, year 2022. Accurate and timely surveillance informs evidence-based decision-making at all levels. All health facilities in Uganda are mandated to submit weekly reports on the 13 notifiable diseases every Monday of the week through the M-Track system. The Ministry of Health reporting rate target is 80%. We conducted a project to improve weekly surveillance reporting from Bara District from 27% to 80% between week 22 to week 34, year 2022. In this case, timeliness was the proportion of all expected weekly reports that were submitted by 12 p.m. Monday of the following week. Completeness was the proportion of expected weekly reports that were submitted by 12 p.m. Wednesday of the following week. To improve reporting, weekly SMS reminders were sent every Monday to health workers through M-Track system, and for motivation, appreciation messages were sent to facilities reporting on time. To ensure consistency in reporting, more health workers were registered in the system. Phone calls were made to non-reporting health facilities and later visited. Those facilities were not reporting or had slow response. To track the progress in reporting, data was analyzed on a weekly basis per health facility. Reporting increased over time, and by week 34, reporting was at 89% completeness and 85% timeliness. There was a drop in completeness and timeliness in week 32 to 50% due to system challenges. This graph shows completeness of weekly reporting for week 22 to 34 from Bara District in Uganda. And on the y-axis, we have reporting rates in percentages. And on the x-axis, we have epidemiological weeks that is week from 22 to 34. And the interventions we implemented started in week 25. And you realize that there was an increase in the reporting rates, except for week 32, where it dropped 50% due to the M-track system. We had issues with the system. And this table shows us the timeliness of reporting. And on the rows, we have health facilities that were reporting. And on the columns, we have weeks. That is week 22 to week 34. T is in green. It represents reports submitted on time. L, reports submitted late, and it's in yellow. Then M, reports that were not submitted by facilities, and it's noted by red. And those that are in green, as a district, those were reported above 80%, and those between 51 to 79 in yellow, and those that reported below 50% were in red. We therefore concluded that weekly reminders, appreciation messages, registering health workers in the system, phone calls to health workers, increased timeliness and completeness of reporting. We recommend that Ministry of Health continuously monitor, give feedback to health workers, and ensure a well-functioning system to improve data quality. Thank you so much for listening.
Questions? Yes. Microphone.
Thank you very much for the wonderful presentation. You can call me Samuel. I'm wondering, since 2022 has ended, why didn't you use, let us see the whole picture for the year, starting from week 1 to week 52, since I believe there's the data, unless the data is not available. Thank you.
Again, thank you very much for the excellent presentation. But just a quick question. Are you having any suggestions of scaling up this beyond Mbarara district?
Yeah, thank you very much for that beautiful presentation. My name is Dr. Kadivane from Kenya. I'm just wondering, beyond this period that you have had, up to 34 weeks, what has happened? Number 2, is the issue about sustainability of that particular intervention. Thank you.
Salomon? Yes.
Yeah, thank you. I didn't know that I have to introduce myself now. My name is Salomon Corville. I'm a medical epidemiologist. Okay, that's good. Okay. Thank you. Wonderful presentation. But I have 3 quick questions. You are a graduate of the FETP Frontline. Do FETP Frontline training contribute to the improvement of timeliness and completeness of those surveillance data? It's the first one. The second one, I'm going to have the second one only. The second one, did you see some improvement in the epidemic-prone diseases detection? You show only timeliness, then at the same time, did you see that more epidemic-prone diseases have been detected?
Thank you for questions, Sylvia. You have the floor.
Thank you so much, colleagues, for the questions and the comments. To begin with, why only these weeks? These weeks were under the study, but after that, the data is available, and it shows that there was a great improvement since then. We have never gone back to 27% as a district. After this, the performance has really been above 80%, as recommended by Ministry of Health. Then someone asked about beyond Mbarara. This is something that we did. And we believe, and in our recommendations, we requested Ministry of Health to take it up to the entire country. This was just a case study of Mbara district, but we believe, and we made recommendations that Ministry of Health scales it out up to the whole country. And I think that would be very good. And as I mentioned, as a country, I was looking at our performance. We are all now above, or when you look at the graph for the whole country, we always in green with a few districts that are usually in yellow, but I believe this also contributes a lot even to other districts and even other countries. What happened, and sustainability, as I've already mentioned, after this, we really found out that there were challenges that we didn't know at the district level. Like we had registered some health workers, but some of them were not registered, so we identified this. And this maybe connects me to someone who asked about the FETP training. Actually, I think I didn't mention it very well, but in the table, it shows that before the training, our performance was not good.
Sylvia is very good for your response. We can move to next presentation. Thank you very much for your contribution.
Okay, thank you so much, colleagues.
Okay, Sadio Abdirahman and Stephens Okumu. Is it in? Okay, thank you. You have 5 minutes. Thank you.
Good evening, everyone. I'm Dr. Saeed Ogedi, an FETP cohort 3 graduate from Somalia. And at the same time, I work with the National Institute of Health as FEOC Emergency Planning Officer. Today, I would like to share the investigation that I conducted in Hoden district, Banada region, Somalia. To begin with the introduction, I would not be very brief. I'll try to be brief because my colleague just mentioned about dengue fever. I would like to just add, like, globally, half of the world population is at risk of contracting dengue fever, and this is prevalent mostly in the tropical and subtropical regions. In Somalia, the emergency department of the Federal Ministry of Health was notified of a dead case and 2 confirmed cases in Banada region in October 2022, while the first case was confirmed in September. So there was 3 weeks delay in the notification to the Federal Ministry of Health. Therefore, this investigation was launched to confirm the existence and verify dengue fever outbreak, as well as to perform epidemiological description by time, place, and person, and also to recommend control and preventive measures. We conducted a medical record review from using the World Health Organization case definition to identify the cases from the facility records in Hoden district during this time period from September to December. And the blood, as you see, Hoden district is one of the 17 districts in Banada region, and the population is 165,000 with 51 health facilities, out of which 3 are just public and the other rest are private. And in this, it lies in the southern eastern part of the Banada region. So the blood samples were tested by using NS1 rapid diagnostic test, as you can see. And the case was confirmed positive after IgM was confirmed with the rapid test. We also explored risk factor by visiting a few households by using a questionnaire, and if I continue with the results, we identified 147 suspected cases, out of which 14 were confirmed. That shows 10% of the cases were confirmed. The overall attack rate was 89 per 100,000 population with a 0 case fatality rate. And you can see the the epi curve, we can see multiple peaks. And the first index case was notified in September, as I have just mentioned before. And then we see multiple peaks showing a propagated source of the investigation. And therefore, the highest number of cases were notified in November. If we continue with the gender distribution, males were more affected than females, and in the age group, the above 14 were more affected. With the clinical presentation, fever, 100% of our cases presented with fever and malaria with 83%. And I forgot to mention that Hoden district have 4 subsections, out of which canine reported the most cases with 53%. For the risk factors, out of the 147 cases, only 1 case had a travel history, and we did observation in the community and the households that we interviewed. We saw some man-made. You can see the water stringent areas, the tires. There was no waste, proper waste disposal in the region, and most of the people were not using any mosquito repellents or the mosquito nets. And you know, dengue is being transmitted in the daytime, so due to the hot weather, people were more wearing, short clothes. To conclude, the dengue fever outbreak in Hoden was confirmed, and we conducted community health education. Me and my colleagues, we translated the WHO risk communication and community engagement materials into Somali, and we distributed to the communities in Hoden district, as well as we educated the health workers. As we know, malaria is endemic in our country, and people are not much familiar with the dengue virus. Therefore, we had to sanitize the health workers more with the case definition of dengue, and also the ARPO line list was provided to the. So I would like to recommend our recommendation. Further studies are needed, especially immunological studies, to discover more about the risk factors in depth and the type, the serotype as well, and also to train, to do more training so that we can improve the capacity of the health workers for early case detection and case management. Therefore, also we need to improve or increase, I must say, our vector-borne control measures by providing more commodities such as mosquito repellents and as well as mosquito net beds to those who are high-risk population. I thank you all for your attention, and I would like to just show you, this is one of the, yes, one of the risk communication material that was translated in Somali.
Thank you, Sadio. Thank you, Sadio. 2 questions. 2 questions. Okay.
Thank you very much. My name is Anthony Dondim, and that was a very good presentation. My question is the confirmation of dengue. Is it the practice in your country that you confirmed using IgM? Or do you have another way of probably sending some of these samples for further confirmation using molecular diagnostic techniques? Thank you.
Thank you. Any questions? Yes.
Yeah, my name is George. That was a wonderful presentation by all standards. In your epic curve, I saw an indication of first index case. So I was hoping to see a second index case or something. So if you can throw more light on that, if there was any.
Okay, Sadio.
So we just have 2 questions, right? Thank you for your questions. If I begin with the first question about the confirmation of the dengue cases, we had shortage of laboratory specimens. So we did confirm the IgM using the NS1 rapid diagnostic test kits. So we got the confirmation from the rapid diagnostic test kits with the NSI. And if I proceed to the second question about the index case, if there were any other preceding cases, I told you that this was a study that we did a medical record review. So by the facility, we were investigating the cases that were in the health facilities. So in September, there were very few cases, but the outbreak started to peak in October and November. You could see there was a peak in November, like there was almost 18 cases in one day. So that showed, like, you know, the outbreak. And then you saw there was a decrease in the cases because the vector control measures were, you know, implemented. The Ministry of Health came into action, and there was more community awareness, and people were getting the more education. Thank you very much.
Alors, félicitations, félicitations. Voilà.
Fine. I think on the issue of confirmation, this was meant to help us understand that we have levels where we have confirmation with what is molecular biology. I think on the issue of confirmation, it has just been indicated that at specific levels, we have other levels of confirmation. Here, I think you took an operational definition to carry out the study, and you need to be more specific on the term so that we don't confuse. For example, if there are other means of confirmation in the country, because RT-PCR and Lassa are the levels where we resort to for confirmation of cases of dengue fever. So we need to insist on the presence of the virus. For TDR, we can have the probable cases in most cases. So these are additional points that you may need to include in your study for improvement. Congratulations for this brilliant work. And now we can invite Stephen Opio. Stephen Opio.
Okay, good afternoon, everyone. My name is Stephen Okumu from FETP Kenya, cohort 18, advanced FELTEP. So, my poster is titled Assessment of Preparedness for Ebola Virus Disease Outbreak at Points of Entry and Isolation Sites in Western Kenya counties in 2022. So we all know Ebola is a viral hemorrhagic disease of public health concern. In September of 2022, Uganda declared an outbreak of EVD of the Sudan type. And by October 2022, we had 130 confirmed cases of EVD with 43 deaths, giving us a case fatality rate of 33% and 6 healthcare workers. So Kenya, as we all know, borders Uganda with a lot of cross-border trade. From this map, you can see Lake Victoria, and from the red point was the epicenter of the outbreak. So we can see a lot of cross-border trade by air and by water. So our study aimed to evaluate the capacity of the points of entry to detect and respond to EVD cases, identify gaps and challenges in the implementation of EVD preparedness. So our methods, we did a mixed method study that is both qualitative and quantitative. We administered a semi-structured questionnaire adapted from the WHO, and our methods included site visits, interviews, and key informant interviews. Is there a complaint? So among the response pillars that we looked at were rapid response team, passenger screening, notification, among others, and our protocol was approved by the Ministry of Health. No ethical clearance was required for this study. So we examined all the 5 points of entries in Kenya and 4 isolation facilities. Qualitative data was analyzed using Excel, while the quantitative data was analyzed using NVivo. And for the quantitative data, each yes answer was awarded at 1 point, while no under 0 point. The POEs and the isolation center were expected to score 100% in all the pillars. So those are some pictures from the point when we were conducting the assessment. So on to results. These are the scores that we had from the points of entries, that is Kisumu Airport, Kisumu Seaport, Isbania Border, Miuru Bay, and Beta Point. And what you can notice is that all these points scored less than 60% and below. So these are further results on the pillars. We had coordination, environmental hygiene, chlorine mixing, IPC. These were the best performing, while issues of lab specimen management, PPE, RRTs were poorly performing in the points of entry. From the key informants, some of the key informants mentioned that they were not prepared and did not have, they were not prepared and also understaffed. For those who will have time, you'll read through the quotes after this. We concluded that the 3 counties were not prepared to detect and respond to an EVD outbreak, and there was a need to strengthen preparedness and response capacity of the point of entries and isolation sites to prevent EVD and other viral hemorrhagic fevers. So we recommended deploying more staff to the point of entry, training all staff on EVD surveillance and response. Counties were to prepare isolation centers with all the required logistics. Government was to set strategies on how to control illegal entry points. Construction of ideal holding rooms for EVD suspects was also recommended. For public health actions, we undertook a rapid responders training in all the border counties. We also came up with
Thank you, Stefan. Thank you. Thank you. Two questions. Question. Okay.
Thank you. Thank you again for another excellent presentation. This morning we heard that public health has no borders, and you're talking about the border between Kenya and Uganda. Don't you think in your recommendations you should be recommending also some joint activities with your colleagues on the Uganda side?
Okay.
Okay, thank you very much for your presentation. So I just have 2 questions for you. The first question is the point of entry that you conducted the research on, are they designated? Are they designated by WHO under IHR? And the second question is, where in your questionnaire, were there questions on whether they were trained previously on the IPC and the things you were looking out for in your questionnaire? Thank you.
Okay.
Okay, thank you for the questions. I did not recommend joint cross-border activities because they are ongoing. We have a lot of cross-border activities going on with Uganda currently. And on the POEs, yes, we looked for all the gazetted. In Kenya, we use the word gazetted. So all the gazetted point of entry, and those are the ones that we assessed. On the training, yes, we asked whether they had been trained before, and some had the knowledge from the previous outbreak and not this one. Thank you very much.
D'accord, merci bien. Je pense que pour que effectivement vous améliorez la surveillance et la réponse au niveau de ces points d'entrée, mettons l'accent bien sûr sur la formation.
This is on the training and setting up of emergency plans at the point of entry and working with the contribution of actors working at the point of entries, and to be able to test all that. And also your recommendation should be more clear to enable you to have good plans, and these are priorities at the international level. So I think we'll be able to do that so that you can face better intervention. So thank you, Stephen.
Yes. Ghislain Alain et Mohamed Saleh Ama se préparent. OK, merci.
W.
OK. Ghislain, on s'excuse.
Ghislain, I think we have some technical issues to sort out. Mohamed Saleh will take the floor.
We return to Ghislain in a few minutes. On peut y aller.
Je peux commencer?
Oui.
Bonsoir à tout le monde.
Traduction.
Bonsoir à tout le monde.
Good afternoon. I am Mohamed Amar. the FTP from trial Mauritania. I'm a veterinarian by training, and I work as the regional director at the Ministry of Livestock in Taga region in Mauritania. I am thankful to you for the opportunity to make a presentation of this work, which is titled The Epidemiological Profile of the Rift Valley Fever Among Animals in Mauritania, August 2022. Following this suspected case in Mauritania, the Livestock Department organized and carried out a study through an inquiry sheet, through blood samples for domestic animals, camels, cattle, and others. So that is the yellow fever, Rift Valley fever, sorry, is transmitted from animals to human beings with complications that are very serious for human beings. This study was based on, as I've already said, based on study sheets through the blood samples on camels, donkeys, and horses. These results showed that majority of the animals were affected, and at the same carried out in various areas in east of Mauritania. When I talk about east, Mauritania is the border with Mali and that with Senegal. And the eastern part of Mauritania shares a border with Mali, where we have animals that are in transhumance between Mali and Senegal. At the same time, this is a humid area that has a very high percentage of animals. So through this study, we noted that there are 2 or 3 areas that are highly affected, particularly the region of Dodori, which represents a high 30% rate of positivity of the Rift Valley fever. It is a northern region that posted a very high positivity rate in Taga region, where I work. If we look at results across time, we note that this epidemic of the Rift Valley fever hit camels, and we noted that the infection period started so it starts on the 25th week and ends with the 42nd week. That means that the disease coincides with the rain period. We noted that this period, the rainy season, is where the disease is highly detectable. Sorry for the way the speaker presents. We can't follow him clearly. In conclusion, we noted that the Rift Valley fever is still an endemic disease in Mauritania. That explains that we really need to carry out advanced studies to better the virus, and at the same time that calls for a lot of coordination among the veterinary services and those involved in human health. So in this regard, I recommend for the last 10 years, we noted that if every year between August and October, we have cases of human beings that are infected, and the numbers are high. So this disease calls for studies, advanced studies, in order to see the risk factors in Mauritania. Thank you. Thank you very much, Mr. Saleh Aima. Any questions? Please come on with the questions.
Okay. Yeah, thank you very much for the wonderful presentation. I just want to find out two issues. Why did you decide to study the disease in camels? Is it not also associated with other animals? And then, is there any reason why the incidence of the disease was common during the rainy season? Thank you.
Okay.
Non. Je réponds au nom du docteur.
Dr. Prosper Imou.
Je n'ai pas bien compris.
I did not really understand the study at the beginning, because the theme is epidemiological profile. And when you took the floor, you said that you had some suspicions. These suspicions are the ones that led you to undertake the study. Yet, I think if it were out of suspicion, you are going to carry out an investigation. However, you preferred to determine the epidemiological profile, but in conclusion, you are saying that the country is endemic in the country. If the disease is endemic in the country, in the problem statement, you ought to have indicated that the profile is not known in the country as a problem, so that you can determine that profile, instead of telling us that you had suspicions and they are the suspected cases that made you carry out these studies. So were there abortions and so on? You needed to first of all talk about an investigation instead of an epidemiological profile, because in your conclusion you say you end up by saying the disease is endemic in the country. Thank you. Perhaps I can throw in a second question. Given the disease is endemic, I believe you vaccinate. Do you vaccinate? And with regard to your results, weren't there any false positive cases? Cases of false positive? Please proceed and respond to the questions. The first question posed to you was to know why you decided to carry out these studies on camels. Thank you for the question. For the first question, with regard to the choice of camels, we noted that the prevalence rate, after a study, we noted that the prevalence rate among the camels was higher than that among other species. And the livestock farmers are in contact with the camels, and they are the most affected compared to other animal species. That is why we focused more on the camels. That is for the first question. For the second question? It is seeking to know the reason why you carried out this study. I think the second contributor was asking you to better frame the title of the study, because the way you have framed the title, it seems it is an investigation. We did a field study between August and September in the 8 areas sharing a border with Mali and Senegal. That means that the study was done with a lot of groups at the same time and across these 8 regions. So we did this inquiry, and the data the samples were analyzed at the laboratory. That is the serums of the animals, and that is why, with regard to the vaccine, that is something else. Vaccination is a decision, a strategic decision, and that requires an inquiry or a study to check out the prevalence rate. After that, a decision, a scientific decision is made, and as well as strategic decision at the central and ministerial services, and that decisions can be made as to whether or not to vaccinate. Thank you very much, but I think the various questions that were raised and the answers that you have given, I would propose to you that next time, in order to justify your study and make it very clear, you need to tell us why you picked this design, and you should not be telling us, as the second speaker said, so that you can formulate that as an investigation. So you went to the field. What really inspired you to go to the field? Was there a problem? Did we have some notifications? Did we have some concerns of public health that led you to that, or was it through literature review that made you identify an issue of public health interest and you put in place necessary protocols for your study? That is what is asked of you, and your results are very clear, but it's important for you to organize them and improve that part of justifying the study, motivating the study. Congratulations for the important work that you have done, and please integrate the suggestions to improve your work. You take.
So, good afternoon, ladies and gentlemen. My name is Sergei Simon, and I'll be sharing with you our findings on descriptive characterization of yellow fever cases in the Upper East region of Ghana. By way of background, yellow fever is endemic in Ghana with periodic outbreaks. In 2021, about 76 cases were confirmed, and about 17, we had 17% case fatality rate. And the Upper East region is one of the districts in Ghana that record as more of the cases. And secondary data analysis is usually done to be able to respond to these cases. Therefore, we sought to describe the epidemiological characteristics of yellow fever cases and to identify the hotspots and to put in place interventions. To do this, we relied on the yellow fever surveillance data, and we did some secondary data analysis. And study was done in the Upper East region, and this is the region showing the 15 various administrative capitals, and the region has to border with Burkina Faso and Togo. We actually relied on the yellow fever case-based forms, the line list, and also the district health information management systems. Variables such as age, sex, community were extracted. And we also looked at trying to do some descriptive measures, such as frequencies and proportions. And we presented our results in terms of charts and maps. For the period under review, 2 confirmed cases were recorded. However, the laboratory turnaround time was above 2 months, and this means that there will be delay in public health response. We also observed that for the period, children 0 to 4 years were most affected, followed by 5 to 9, with the least being 65 years. For the hotspots, we also observed that most of the suspected cases were coming from Pusigat district, and this is a border town where there was an outbreak in Burkina Faso in 2020, and that led to some active case search. We also observed that the 2 confirmed cases were recorded in Boko Municipal and Bolga East district. For the trend of the cases, we observed that for the period under review, most of the cases were recorded in May up to October. And these are periods where we have rainfall patterns, and we all know that this serves as breeding ground for mosquitoes. Vaccination remains one of the cost-effective ways of preventing yellow fever. However, during the period under review, we observed that most of the yellow fever cases, vaccination coverage was below the national target of 95. And this means that there will be accumulation of susceptibles which can lead to outbreak. So we conclude by saying that there has been an increase in suspected cases over the period under review among males and children under 5. And Pusigat district recorded most of the suspected cases. And there was suboptimal yellow fever vaccination coverage below the national target of 95, and also observed that there was delay in laboratory feedback from the National Public Health Reference Lab. As way of recommendation, we recommend, among other things, the need for routine mop-ups campaign in the region, and also the National Public Health Reference Lab, ensuring that there are timely laboratory feedback. By way of public health actions, we did some sensitization among surveillance officers in the region, and I must point out that this led to more cases being detected, and especially in 2022, we had so many cases that were recorded, and we did some public education and at the radio station. Thanks for your attention.
Okay, merci bien.
Thank you very much, Simon. Questions?
I want to really appreciate the presenter. He's done an excellent job to summarize everything that we needed to know. But I'm really curious about the long turnaround time of up to 2 months. I want to ask whether you have a surveillance system for yellow fever as a disease in your country, and whether the system has been analyzed. Thank you very much.
Thank you very much. I was about to leave when I heard yellow fever because of the importance. I'm sure most of us were allowed to enter here because we show evidence of our vaccination. So this is very important. Thank you very much for the presentation. From your results, I saw that consistently, and you even concluded on that the region has low vaccine coverage for yellow fever, and from the results, we could see that only 2 districts were able to achieve that 80% or is it 90% national coverage for your country consistently. However, one of those districts was among those who reported the highest number of suspected cases. Can you explain this? Thank you.
Okay, je pense que c'est bon. You can respond.
Your questions. For the first one on the laboratory turnaround time, actually there's a surveillance system that is in place to detect and also to report and to get feedback. Actually, our findings we did some analysis and we realized that it was actually the delay comes as a result of the transportation, especially in the place that we are coming from. So in a week, they send samples only on one day to the headquarters, and actually that brings the delay. For the next question on the Pusiga districts, it's a border town, so you have most of the people actually sharing boundaries, and you have influx of people also coming from that community to access services at the Pusiga districts. And actually, they are like this morning we heard that there are no borders, so you have influx of people moving from those neighboring countries to access health services. I hope I've been able to respond to your question. Thank you.
Ok, merci bien. Mais est-ce que tu as essayé de rechercher les couvertures vaccinales de l'autre côté de la frontière? Parce que quand je te suis, je dis que tu devrais effectivement rechercher dans le cadre de la collaboration entre les parties du Burkina Faso et puis ce district frontalier-là. Et au niveau des actions de santé publique, je ne note pas une action.
In terms of public health actions, I didn't see anything about strengthening vaccination. I think you need to be more complete, because this is a beautiful study, but you have to talk about prevention in terms of public health action. It is good, but we would like to improve your work. Thank you very much. Congratulations for the work well done.
We have to hear now Ghislain Alain.
Bonsoir à tous.
Good afternoon. I'm Ghislain, frontline from Central African Republic. I'm privileged today to present characteristics of yellow. That is a case that was for 2022. Since 2022, 12 countries were classified as being at high risk in the Central African Republic. In October 2021, June 2023, we had 21 cases of yellow fever, which was 17% of the cases. In November 2022, in Busomba and Bagi, a new case was confirmed through neutralization. For that, an investigation was carried out around the case in order to describe the case epidemiologically and see the extent of the epidemiology and propose control measures. To get to the results, a descriptive study, cross-sectional descriptive study was carried out from the 1st of October to 22nd December 2022 in the Mbaki district in the municipality of Pisa. The study variables were H media and the entomological study was done for the mosquitoes. For data collection, we examined registration records and we did an entomological study, the percentage of vaccination coverage, and we did the necessary calculations. We have some photos that are from the study that we carried out in the Mbaki and Bisa municipality during this study that enabled us to look at the various consultation records and the active research within the community, as well as vaccination of the people enlisted for capture of mosquitoes. Ladies and gentlemen, our case was a lady, aged 32 years, who was consulted in September 2022 in the PISA Medical Center in the context of the fever, and there was a blood sample that was drawn and case confirmed 24th November 2022. 4 new cases were identified. 2 were men, 1 and we had 300 who were not vaccinated. This information shows clinical signs, which are the most common ones, that are high fever, fatigue. The suspected cases were picked, tested negative. This figure shows the trend in the case of yellow fever in the health center of PISA from the week 29 to week 52. On this graph, we see the notification of cases was done at week 50, and confirmation was done at week 58, and the investigation carried out on week 62. The quick inquiry on coverage of vaccination was done in 11 we had 327 who had been vaccinated against yellow fever. We identified 7 sites where we captured mosquitoes where the IDS was not captured. In conclusion, we can say that it's about an epidemic of yellow fever with high risk. Vaccination coverage is low. To say that we need to improve vaccination coverage and communicate on the risk of yellow fever in order to tame the pandemic. On that, we can't fail to thank our Ministry of Health, WHO, and AFENET. Any questions on that work by Jocelyn?
Wonderful presentation. But I wanted to see the public health recommendation, since globally these infections are cut across issues.
C'est bon? C'est bon?
Kindly come again with your question.
I think it's a wonderful presentation, but I wanted to see the public health action. Since these infections are just cross-border issues, we have it in Sierra Leone, we have it in Ghana and other countries, but I'm not seeing that here. Thank you.
Okay. Autre question?
Do we have any other question? Thank you very much. Actions that were carried out, recommended, was control measures in the Mbaki. These initiatives were carried out with a vaccination that were at a level of 70%. I think the entomological level that you have presented could not give the ADS, and I think this needs to be followed through. Is there a research center that does an entomological surveillance that would help us understand this phenomenon with the cycle for the capture of these mosquitoes? I think this entomological aspect has to be pursued further. Otherwise, thank you very much for sharing your work. Congratulations. We will conclude with Mr. Musa Amadou, who will look at the evaluation of the surveillance system for yellow fever in the region of Niamey in Niger. You have 5 minutes for your presentation. Please proceed with your poster. Thank you very much, Chair. I greet the audience. I'm Musa Amadou. I am a trained doctor. I am from Niger. I am honored to make this presentation on the results of my work carried on the evaluation of the surveillance system for yellow fever in the Niamey region, Niger 2022. The yellow fever has been talked about a lot this afternoon. This is one of the main viral hemorrhagic fever, which is vectorial. We have a very effective vaccine against yellow fever. That's important to note. Niger is one of the high-risk countries for yellow fever, according to WHO. So our system ought to be very reactive in order to detect the outbreak of the pandemic and act appropriately. We need to note that the current or recent history of outbreaks of yellow fever across the world has shown that this epidemic attacks populations living in urban areas and where vaccination coverage against this virus is low. We therefore decided to evaluate or assess the surveillance system for yellow fever in the region of Niamey, and this is the region that hosts the capital of Niger, which is Niamey. The methods that we used, we need to note that Niamey has 3 districts and 5 health centers, and this is the matrix that shows you information circulation from the community integrated health center. Then it goes up to the regional health center, regional, and the directorate of epidemics, up to the national focal point for WHO. This was a descriptive study which we carried out from 1st June 2023 to December 30th, 2022 to December 2022. We looked at the cases of yellow fever at all levels, and in order to collect our information, we used the reference table for WHO for the systems of surveillance of the yellow fever. We also use the CDC framework for the assessment of surveillance systems for public health to assess some aspects of the system. We assessed the usefulness and the characteristics such as simplicity, acceptability, sensitivity, as well as representativity or representativeness. We looked at the linear list from January 2022 to December 31st, 2022, for purposes of this study. The data was collected and analyzed by help of Excel software. We had a scale to judge the attributes or characteristics. If 25 to 49 was low, 49 to 59 was average, and above that was strong. The results of our work: the first table summarizes the assessment of the performance of the surveillance system for the yellow fever. This system was generally found to be performing because we have assessed 6 indicators. The first one was at 100%. Then sensitivity. The system allowed to notify 30 suspected cases in the region during the period under study, and this period was found to be sensitive. The representativity: the 5 districts of Niamey notified all the cases as appearing in this graph. So the system was found to be representative. In terms of reactivity, the system was found to be generally reactive, not reactive, but the system was found to be simple, and its acceptability was, the system was found to be acceptable. In conclusion, the performance study for the performance of this were achieved. Thank you. Thank you. Questions? Thank you very much for the floor. Thank you, Musa, for the work that you did. Nonetheless, we have a lot of things that I did not understand. In the methodology, you did not explain to us how you calculated sensitivity, or rather the characteristics or attributes. You finished by saying that the fact that there was detection of 30 cases, the system is already sensitive. Yet, normally, if we need to know whether a system is sensitive, we look at the definition of the cases. We need to see how many cases were notified and how many were not notified. So I thought that for these characteristics or attributes were going to be presented in percentages. For example, at 90% or 60%, and that would show us whether the actors of surveillance really understand the case definition. By the representativity, you needed to give us a representativity and the timeliness. There are others that were at 4, and so it was not 4. It was not 100%. You said representativity was good. Reactivity, you said that it was the system was less or least reactive. But you need to give us the timelines, because we need to see the timelines. They detect, when did they detect, when did they react, and when did they notify? So those details did not come out. In regard to simplicity, you didn't tell us whether the system referred to specific cases. I think those are the improvements you need to make in the work. Otherwise, we need to have recommendations targeting these weak areas. Thank you.
Thank you very much. I am Andrew from Sierra Leone. I want to ask you on the method you used to do your system evaluation. You said you use the CDC guidelines and then the WHO guideline. If you are doing a surveillance system evaluation using any of those guidelines, I want to believe most of the attributes you assessed could either be quantitative or qualitative attributes. But what I did not hear from your methods was which data collection technique did you use in assessing those attributes. I also did not hear you telling us who were actually your study population. Whom did you target, and how were they selected? Thank you.
Ok, d'accord, merci bien.
Thank you.
I will respond to questions raised by the first speaker. It's true that towards the end, because of time, I quickly brushed over several things. There are certain details that you can get through the poster. If you look at the posters, there are some details that you will get to respond to your questions. But if you take for the case of representativity or representativeness, the graph that I presented were just figures for the cases, are not proportions. These 4 cases that were notified, these were put across the 5 districts. We had a district that shared the list number, which was 4. Others had 7. So we actually, most of the districts in Niamey had notified the cases, and that is how I captured representativeness. And for the number of cases, we also did an analysis on the cases that were notified. We shared out, we disaggregated it in terms of the gender. And then we also did a disaggregation in terms of age and status of vaccination against yellow fever to see whether the system can detect the cases across the various groups of the population. So I request you to look at the poster and get the posters. With regard to reactivity, it's the same thing. On the poster we have details because the reactivity was assessed across 3 levels. The border, the central, the intermediary and the central levels near the reference center. So when we carried out the study, we had a challenge with regard to transmission of notification of information from the district to the higher level. But generally, as I said, we fixed a threshold score so we fixed the threshold score, and our results helped us to deduce that the system was sensitive. But for details, you look at the poster and you'll see that we have a table that really gives the time, recaptures time across the various levels, from the border levels to the intermediary levels to the central level. Please, would you have some time and look at the poster? Thank you. The second question relates to the methods. I said that we used the assessment framework for performance surveillance systems for WHO 2017. On the basis of the indicators that are spelled out, we were able to see whether the surveillance system for yellow fever in the Niamey region is performing and what are the reasons. So we looked at indicator by indicator, and with regard to every indicator, we have a reference. And finally, we, on the basis of the data from the surveillance system for yellow fever, we were able to calculate what the system led to with regard to the calculation of every indicator. So we noted on the table that we have 6 indicators for assessment of performance. The other first indicator was at 100%, and the next one was at 70%. That is why we said that the system was performing. The other aspect of the techniques of data collection, the population, as I said, we used the CDC framework 2021 for assessment of public health systems. You know that we needed to go through a study to assess certain characteristics. So the population for our study was the actors involved in the surveillance of the yellow fever across the various levels of the health system in the country. So we thank you, Musa. Thank you very much, Musa. I think the questions that were raised to you need to be taken seriously. That means that you have a methodology that targets various residents, and we ask people to use the various characteristics inscribed in the CDC model. Why did you not finish the work with that? Because normally we get to that point. Without that, if it is done in the best conditions, he raised a couple of aspects, and we'll need to take time to go into details for these attributes instead of doing a method mix that are not really explicit. This work, I think, is okay. You are committed, but I would wish you to, with thought to improve it, you need to look at the implications and use what you have been taught, what you have learned, and what you need to use and promote. I think these characteristics or attributes, well, you took time to look at your protocol, to determine the key aspects, aspect by aspect, in order to get to the fact and tell us whether the system is futile or productive. I think that is what we are looking for in your presentation. And my question is to know whether you calculated the VPP. We did not seek to look at VPP, but we assessed the representativity, sensibility, acceptability, and reactivity. So that is the point. I think these are the things, you know, when we tell you that, is to call on you to push the work further, and because the decision maker needs something that is convincing. If you will present that as a director of surveillance in Burkina Faso, I would not understand that, and I would talk to your in charge, because I know that model, and I would be telling your in charge that we need that, because fever, yellow fever, is a concern, and we need to follow this through and through. And I know my colleagues who are involved, and they can make decisions to put in place various actions. So thank you very much for that work as done, and I wish you all the best. We have come to the end of our session. I thank you very much for the support that you have given. We thank and congratulate the various presentations. We saw very bold presenters, ladies and gentlemen, and I hope every one of us has drawn some input in order to enhance our public health interventions. So we will end the session, and we will give the floor to our colleague from AFENET. He's not using the microphone. We can't hear him. We have a session that will be starting now. We'll ask Dr. Tefeni. Thank you very much, the Director of Public Health in Burkina Faso. Thank you very much for the assessors. Thank you very much. We will continue. It is just 8 people. We have only 8 people. The previous one had 12.
Je sais que les interpréteurs, vous êtes trop fatigués.
So we just want to take this time to invite you all to the second oral section that will focus on the sub-theme, the maternal, reproductive, and child health, HIV and AIDS, tuberculosis, and other opportunistic infections. So I will be moderating this section. I'm Dr. Ralph Jitter, the director for the Liberia FETP, and as well director for the Division of Infectious Disease and Epidemiology at the National Public Health Institute of Liberia. I have with me my evaluators that will actually support this process. So can we just remain very much engaged? I will be very strict on the time. We're all aware that this is 10 minutes, but we will take another format because we do not have time. So there are 8 presentations. And so we will take the first 4 presentations, and then we entertain questions and answer, and then we do the second 4 presentation. Because interpreters are exhausted, and so we will beg your indulgence to keep, bear with us within that strict amount of time. So having said that, we will just take the first presenter. We will now call on Malaku Hila, who's going to present to us surveillance data analysis of tuberculosis in Oromia Zone, Amhara region, Ethiopia. You can take the stage. Thank you. So again, we'll emphasize you have 10 minutes for your presentation, please.
Okay, thank you. Welcome to my presentation. My name is Malaku. I am from Ethiopia, field epidemiology resident. My topic is about surveillance data analysis of tuberculosis in Oromia Zone, Amhara region. This is my presentation outline. Just to begin with a brief introduction about tuberculosis. Tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculosis, as you know that, it is known. It mainly affects the lungs. Estimated of 10.6 million people were infected in 2021. And most TBs were from Southeast Asia, Africa, and Western Pacific. Africa continent, almost quarter of cases from our continent. It was the 13th cause of death globally. 20 countries are high burden, 30 countries are high burden, which account 87% of the worldwide tuberculosis case. Among them, 8 countries contribute 67%. Most were males, and Ethiopia ranked 12th among the 30 high burden countries. TB is needed to be analyzed since it is one of the public health emergencies in Ethiopia.
Des urgences les plus importantes en Éthiopie.
To describe tuberculosis case detection rate and treatment outcome from 2070 to 2021 in Amhara, Oromia Zone, Amhara region, Ethiopia. Here is a study area map, which is Oromia Zone. It has 5 rural districts and 2 town administratives. Source population were all patients diagnosed with tuberculosis. Study populations were all patients diagnosed with TB and reported in the HMIS report within the 5 years. Cross-sectional study were conducted. Data were collected from DHIS report and ethical consideration obtained from Bahardar University and Amhara Public Health Institute. Here are operational definitions that I used. Major results are here. A total of, within 5 years, 3,590 incident, all forms of TB cases were detected with case detection rate of 69%. 96% were new cases and 4% were relapse. 68% were pulmonary tuberculosis and 32% were extrapulmonary tuberculosis. with annual average incidence of all forms of TB, 122 per 100,000 population. This is the trend of all forms of TB detection rate, which is in slightly decreasing shows. When we come to the discussion, we found that 69%, this is higher than Benishangul Gumuz and Amhara region in our country, and lower than the national and Oromia and Afar regions. The possible reason for low case detection rate may low presumptive TB screening, lack of more sensitive diagnostic tools like GeneXpert, and sometimes presence of conflict and presence of pandemic of COVID-19 and turnover of trained healthcare professionals. This is trend of tuberculosis by type, and this shows the extrapulmonary TB is increasing, and the clinically diagnosed TB cases are slowly decreasing, and the pulmonary tuberculosis seems like constant. We found that 68% were pulmonary tuberculosis, which is consistent with another study conducted in our country, Desi Hospital. Possible reason for this may increase of primary health care coverage and good awareness of the community about the sign and symptom of tuberculosis. 59% were males, and most cases were age 50 and above, as is displayed on table. From total, this is in line with previous study conducted in our zone of Amhara region, and in contrast to this, it is higher than southern Ethiopia, which were 15 cases were under 5, but ours was 2%. The difference may be based on the estimated of the trend of incidence case by district, as this red line shows the one town administration, which is called KMC, and this is the highest cases, 372 cases per 100,000 on average, followed by Bati town, and the other 5 districts are almost near to similar. This shows incidence categorization. This highlighted with red is with the highest incidence and categorized as highly endemic. The 2 districts are endemic, and the rest 3 districts are categorized as upper moderate incidence categorization. We found that average incidence rate of TB was 122 per 100,000 population. This was categorized as endemic according to the WHO incidence categorization. This is lower than a study conducted in our zone, which was 144, and annual TB incidence of Ethiopia, which was 140, higher than the milestone of WHO 2020 and 2025. Possible reason may be COVID-19 and presence of conflict sometimes. Incidence of KMC town, as I told you in previous slide, 372 cases per 100,000 population was highest of all districts. This may because of presence of incident cases from neighboring districts and zones. We found cure rate and treatment success rate. Success rate meaning those cured and treatment completed was 90 and 95% respectively. The cure rate is higher than a study conducted in Ethiopia and Amhara region, and national lower than Harari region. This success rate is similar with Amhara region and higher than Gambela region and Afar regions. This may be due to the implementation of DOTIS strategy, increased health service coverage, and good adherence of patients to TB treatment. Conclusion: based on the finding, we conclude low TB case detection and higher pulmonary TB cases, increasing of trend of extrapulmonary TB. TB was higher in male and adults. Treatment outcome were achieved as per the WHO target. We recommend further investigation and study of district with poor case detection and high incidence rate. And we recommend expansion of microscopic, gene expert X-ray and culture diagnostic services in order to early detect the presumptive cases, and strengthen TB surveillance, meaning that improve presumptive TB screening, active case search, and contact screening. These were my reference. I would like to acknowledge the following organizations and individuals. In addition, AFENET and the Africa CDC. Thank you for invitation in such amazing conference. I would like to thank all. If you have any question, comment, and suggestion, welcome.
Thank you so much, Hali. Just have your seat. Let me indicate that we'll take the first 4 presentations, and then we discuss it, and then go to the second 4 sets. So we encourage you to take down notes, and then we'll engage and our presenter after the first 4. So Hali, just take a seat here. So now we will call on the second presenter, James McCormick, who will give the Kenyan experience on linking drug-resistant tuberculosis surveillance data to public health action.
Okay, thank you so much for giving me this opportunity. My name is James McCormick, an advanced FLTP resident in Kenya. Currently, I'm supporting the National TB program. So I'm going to share the experience on how the National TB program has linked their drug-resistant TB data in terms of connecting to public health action. So epidemiologically, we know that drug-resistant TB is a significant contributor to antimicrobial resistance. And about half a million people are contributing who are getting this condition fall ill globally. Then again, drug-resistant tuberculosis accounts to about 4.1% of the new TB morbidity, with rifampicin resistance accounting to about 25%. In Africa region, among the new MDR TB patients, we have 15% who have developed resistance to rifampicin resistance. So going down, narrowing down to the Kenyan situation, in Kenya, we have there is an increasing trend of DRTB, which is about 40%. And again, by the year 2020, out of the 47 counties that we have in Kenya, about 33 of those counties recorded new cases. And in these cases, it was recording the cases of rifampicin resistance and also isoniazid monoresistance in Kenya. And a whopping 50% of all these drug-resistant TB cases, they were new patients who have never taken any anti-TB drugs. So in synopsis of this, the National TB program came up with the data drug-resistant surveillance data system so that it can be able to inform, detect, guide, and also investigate to give the public health action and also in terms of epidemic intelligence. So the objective of this study was to showcase how the National TB program has utilized the drug resistance surveillance data to, for public health decision making and also for epidemic intelligence. So our methods was to collect the data, that is 2022 data, which was collected We looked at the policies and guidelines which have been developed, the annual reports and the newsletters, the SOPs and the job aids which have been developed, the data quality audit reports, and the entire national data which is anchored under the TB LIM system, which is an electronic system which anchors out the data for the whole country. And again, the methods that we used an Excel to have some data variables, which include the death rates, the loss to follow-up, the policies and guidelines which have been developed from this data, the cure rates and the treatment success rates, the tracking of trends and patterns, and also the data used for national strategic plan. So our results are as follows. We looked at the trends from the year 2015 to 2022. And as you can see, in the year 2015, the National TB program was recording only 449 cases. This is simply because by that time we had some suboptimal surveillance. We had a very weak specimen referral systems, and also we had very few diagnostic tools for drug-resistant tuberculosis. Then again, in the year 2018, there was an increased number of surveillance labs which were strategically placed in the counties, and also there was some sort of capacity building so that we can increase the clinical acumen of the clinical officers so that they can be able to pick the cases at the earliest time possible. Then again, by the year 2020, we had an increased number of diagnostic tools which were strategically placed. But again, there was a decline in terms of the numbers because of the commodity challenges throughout the country. Then again, in terms of utilizing this data, we found that from the program, they have been able to utilize this data to identify the drug-resistant patients, and every month they are giving them 6,000 Kenya shillings so that they can be able to support themselves. And this is in tandem with the National Strategic Plan and also the NDTB strategy by 2035, which looks at, which embodies that we need to have 0 families facing catastrophic costs by the year 2035. Then again, we have other benefits which have come on board by utilization of this drug-resistant TB. And one of those is development of the programmatic drug-resistant TB guideline. And also it has been able to use them in terms of tracking the drug trends and patterns. And also they have used this data to utilize in terms of developing the national strategic plan, and also identification of the drug-resistant TB hotspots throughout the country, and other more diagnostics technologies which have come on board by utilization of this data. These are some of the SOPs, guidelines, national strategic plans, and policies which have been developed by utilizing that data from the year 2015. Then again, the same data, it has assisted the country to geospatially and strategically identify where we have the hotspots, and again, strategically place the equipment for diagnosis. And as you can see that the western part of Kenya, we have, that's where we have most of the drug-resistant TB, and that's why we are having a lot of diagnostic tools placed in that particular area. Then again, this is as a result of utilizing one of the latest technologies called the diagnostic network optimization, courtesy of the diagnostic network assessment at the country level. So what is the public health impact upon utilization of this data for the program? As you can see here, in terms of the trends, we have the increasing indicators which have been improved due to the utilization of this data. And one of those indicators is the cure rates and also the treatment success rates. If you look at the cure rate, our cure rate has started from 73%, but as we speak now is at 80%, meaning that they have utilized that data to bring on board some interventions so that they can be able to improve the cure rates. And also the same case applies to the treatment success rates at the facility level. Then if you look, we also have decreasing indicators that we want to make sure that they are decreasing, and that is the loss to follow-up and also the death rates. As you can see, there is a decreasing trend, meaning that they have utilized that data to bring on board the interventions to reduce that. So in conclusion, we can conclude that drug-resistant surveillance data has changed the drug-resistant management landscape through policy formulation, evidence-based guidelines, SOP development, and identification of the hotspots. So what's our recommendation? Because in the process of analyzing this, we realized that there are some challenges. One of them was the issues of commodity, which was an issue. So we recommend strengthen commodity security, strengthen antimicrobial resistance, and the prevention of the new infections. As we have seen, 50% of the cases are new patients. Otherwise, we also recommend that they improve and optimize drug resistance surveillance at the facility level. Otherwise, I acknowledge all those individuals and institutions. Thank you so much.
Mr. McCormick, we will then call on Tato Siosa, and who will be presenting to us descriptive analysis of severe immunodeficiency in persons living with HIV and AIDS, Lesotho, from the period of October 2021 to September 2022.
Good afternoon, ladies and gentlemen. My name is Tato Swota. I'm here to present this beautiful study which was done in Lesotho, titled Descriptive Analysis of Severe Immunodeficiency in Persons Living with HIV for the period of October 2021 to September 2022. Lesotho is a very small country surrounded by its neighboring country, the Republic of South Africa. HIV prevalence at the moment is estimated at 22.7% among adults 15 years and above.
Yeah, please, sorry for the interruption. The delegates that will be going to Lassa Resort Beach. If you are here, the boss is willing, and Mubasa Beach Resort. Mubasa Beach Resort. No, but he will have to. You have to stay. So, Mubasa. Yeah, sorry. So we can just continue.
Currently, HIV prevalence is at 22.7%, and for HIV monitoring, the country uses viral load. But CD4 count is still very important in the management of HIV, in that in assessing the degree of HIV-related immunosuppression and in determining some of the screening tests for people with HIV known statuses, we still rely on CD4 count testing. However, continued destruction of the CD4 by HIV eventually results in severe immunodeficiency, and because there was limited information on severe immunodeficiencies, we had to do a study so that we could find more information on severe immunodeficiency. Hence why the study was done to assess characteristics of people with severe immunodeficiency in Lesotho for programmatic interventions. So for this study, 3 objectives had to be met. The first one was to determine completeness of the data which was going to be used in the study. The second objective would be to determine immunodeficiency categories. Then lastly, describe characteristics of people with severe immunodeficiencies. So the study was descriptive. It used information from the National Reference Lab, which is based in Maseru, the capital of Lesotho, and also from other laboratories from different districts. The data which was collected was from people who had gone for CD4 testing from the period October 2021 up until September 2022. This excluded results for under 5s use percentage, while for adults we use absolute numbers. The way the study was conducted, data was collected from the laboratory information system and imported into Microsoft Excel. From there, the data was expressed for data quality errors and then cleaned. Then after that, descriptive analysis was done, and the findings were presented in tables and graphs. Here is the result of the completeness of the data which was going to be used. And clinical information seemed to be the variable that lacked most of the information. For immunodeficiency categories, with regard to severe immunodeficiency, it was at 10%. Now, further, the 10% of severe immunodeficiency, when we further classified it according to age and sex, we found that the age group with most people with severe immunodeficiency was the age group of 36 to 45 years. Further, when we looked at the people with severe immunodeficiency with regard to testing laboratories, we could see that Maluti and Pare were the 2 most labs with the highest proportion of labs with people or that had a CD4 count below 200. Here it was comparing the proportion of the patients with severe immunodeficiency with regard to how many of them had the crypto antigen test done for them. Patients' proportion with severe immunodeficiency was lower than the estimated 30 to 40% of WHO estimate, because here the severe immunodeficiency was 10%. So, most severe immunodeficiency cases found were in the 36 to 45 age group. highest proportions of severe immunodeficiency were detected in Highland laboratories. Crack antigen was performed for 34% of severe immunodeficient cases. Limitations included missing information, lab that faced stockouts, and CD4 counts, testing that was not linked with crack antigen testing in the LIS system. In conclusion, the proportion of patients with severe immunodeficiency was 10%. This implies that for public health, when planning and interventions being put in place, the 10% has to be given priority, and in particular, both females and males equally, with priority being addressed to the age group of 34 to 45 years of age. Recommendations included that the laboratory had to give trainings to health facilities on data quality. Related tests should be interlinked in the LIS system. TB LAM to be introduced for people with severe immunodeficiency. Proper management so that there are no stockouts, and further studies to be done to understand factors associated with severe immunodeficiencies. While the study was being undertaken, TB LAM was not yet produced in the country, but for now, it has been included in the guidelines, and it is now a routine test for patients with severe immunodeficiency. Thank you. I would like to thank the following organizations and individuals. Thank you.
Thank you, Thatu, for the presentation. Just take a seat. We now call on Madaliso Nikata. Sorry if I'm not pronouncing your name well. So he's going to present to us tuberculosis and COVID-19 co-infections at the 2 University Hospital in Lusaka during the period 2020 to 2022, sorry.
Good evening, everyone. I am Madaliso Nikata. I will be presenting on tuberculosis and COVID-19 co-infection at the 2 university teaching hospitals in Lusaka, Zambia, 2020 to 2022. Okay. As a matter of introduction, Zambia, like any other African country, has been experiencing COVID-19 and tuberculosis. So the first COVID-19 case was reported in Zambia on 18th March 2022. So as of 26th September 2022, a total of 333,000 cases, 549, and cases were reported, and 4,017 deaths were recorded. According to World Health Organization, Zambia is classified as a high TB burden country. So an estimated 59,000 new TB cases are reported every month. Sorry, just a minute. So in terms of our objectives, the study had 2 objectives. Number 1 was to describe the characteristics of individuals tested for TB and COVID-19. Number 2 was to establish the proportion of TB and COVID-19 co-infection among those who were bidirectionally screened. So how did we do this? In terms of the study size, we conducted our study at the University of Zambia Teaching Hospital, popularly known as UTH, and the Lev Mwanawasa Medical University, which is known as LMMUTH. In order to answer our objectives, we designed a descriptive cross-sectional study using secondary data of TB and COVID-19 laboratory test results. We defined co-infection as the occurrence of a positive PCR test for both infections within 1 month. So where do we get our data? The sources of data for this study were TB and COVID-19 laboratory test results from electronic laboratory databases covering a period from 14th July to 25th September 2022. Since TB and COVID-19 test results were from different databases, we merged and matched the records using probabilistic method in ARA software using name, sex, and age, a plus or minus 1 age difference as a matching criteria. So the process generated a perfect and possible matches, of which the possible matches were further reviewed, looking at the similarities at least 2 of the criteria that we used. So, data analysis. How do we do it? So the Microsoft Excel spreadsheets were imported into our studio, version 4.31 for analysis. So we managed to calculate median with interquartile ranges, frequencies, and proportions with p-values. We also did the bivariable analysis performed at 0.05 significance level. So what did we find? So firstly, in terms of the TB COVID-19 bidirectional screening test, we initially found that a total of 17,047 TB tests were done, and 126,844 COVID tests were done. So going further, we removed the duplicates, and at the end of the day, after matching, we found that a total of 781 individuals underwent both TB and COVID-19 tests. Going further with the results, we also looked at the description of participants and the test results by sex. So we noted a significant sex and age difference among those who were bidirectional screened at the 2 hospitals. We found that the age difference between the males and the female among those who were bidirectional screened was not significant, as you can note here. On the other hand, when the results were looked in terms of sex, and more males tested positive for tuberculosis, whereas more females tested positive for COVID-19. Looking at the results in terms of the site, we noted that a significant sex and age difference among those who were bidirectional screened at the 2 university teaching hospitals. In terms of TB and COVID-19 monoinfections, at individual site, Lev Mwanawasa Medical University had a higher proportion of TB positives and among those that were tested, whereas UTH had a higher proportion of COVID-19 positives among those that were also tested. Going further, in terms of the co-infection, which was the main assignment for this study, when it comes to the co-infection, we found that the prevalence among those that were bidirectional screened was 1.3%, as you can see here. So whereas the co-infections among the sexes was equal, you can take note that both males and females were equally co-infected, 50% each. But in terms of age, more individuals aged 35 to 59 years were more infected, 60%, with none for those aged above 60 years old being co-infected. So what are we saying in terms of what we found? So although the TB COVID-19 co-infection was low, that was 1.3%, it was higher when you compare these results with the study that was done in one part of South Africa, which found a co-infection of 0.04%. The equal TB COVID co-infection between the sexes in this study was a departure from what others found where more males were co-infected. In our study, we found that both males and females were co-infected. But to note, the higher TB or COVID-19 mono-infections among males as compared to females was similar to what was found in Turkey, again, where more males were infected when we talk about the mono-infection. This study did not go without limitations. We had a few limitations. Number one, we found that there were a few bidirectional tests that were done in these two health facilities. Secondly, the study only covered 2 of the 11 sites that were doing bidirectional screening in Zambia. So what public health action did we take after doing this? What we did was that the preliminary results of this study were shared with directors, coordinators, and key TB and COVID-19 staff at the two institutions for their action. So in terms of conclusion, we are saying that many people were tested for COVID-19, but a few underwent TB testing. And the TB COVID-19 co-infection was generally very low. I thank you for your attention.
Thank you, Nikata. So we want to say a very big thank you to all of our presenters. I think the presentation was, they were all brilliant. We will now entertain questions, and we will really encourage you to be straight to the question because we are actually out of time. So yeah, okay. One, your question should please be directed to the presenter.
Thank you very much. I want to appreciate all the presenters. They did an excellent job. I want to highlight the Kenyan presentation. That was very well done. The points were very well put across. I wanted to ask about the cash transfers and whether you have looked at the sustainability aspect of it, because I know that that's quite a sum when it comes to Kenyan money. For the presenter for Lesotho, that was a very interesting topic, and I wanted some clarification whether the severe immunodeficiency could also be what we call advanced HIV disease, and why children were excluded, because we know that children are more at risk of having immunodeficiency. And then on your CD4 classification, I know there has been a revision on the CD4 classification. So why were you using 200 as a cutoff as opposed to 50 or something that is less than that? Because studies have shown that that is also significant. You left out your public, your response, your public health response, because your reflex CRAG for those who had CD4 less than 200 was 34%. That is very, very low, and we want to know what has been done because of that. Thank you.
Thank you.
Thank you. Through you, Chair, I will just ask very quick questions that you say, but I agree with you. Excellent presentations. To Melaku, your study was about case detection rate, and you were, It's okay? C'est bien? Okay. Your study was about case detection rates, and you were saying they were lower in some cases because you were thinking, compared to other regions, maybe conflict and maybe COVID could be the cause. But when you looked at cure rates and TB success rate, it was just like the national. So why was that difference? And also, were you able in your several years when you're looking from, was it 2017 to 2021, to pinpoint on the curve to say, in the month of so-and-so, there was a conflict, and this is what we saw, if you're able to juxtapose those. Very quickly to James, picture says 1,000 words from Kenya. I liked your presentation, but of course I have to ask a question. I know the difference between 2015 and 2020 is only 5 years, but you were giving raw numbers as opposed to rates. Could there have been changes in populations which could perhaps have changed your numbers? I know it's an academic question which you are very well aware of. To Tato, excellent presentation. In your observation, significantly, clinical information was lacking. But in your recommendations, I don't see any recommendation about improving clinical information in the writing. But others, the study was really informative and excellent. And then, of course, to Madalitso from my neighbor in Zambia, I have to ask something since I'm from Zimbabwe. Why the difference between Levi, Mwanawasa, and UTH in terms of TB and COVID reporting? But I do note that the overall response is that co-infection is only 1.3%. Sorry for the long questions, but I hope I was brief.
Take the final question.
Yes, thank you to all the presenters. I'm Andrew again from Sierra Leone. I will go from the first presenter to the last one. The first presenter, I couldn't get your name right. I think it's Miracle. But then the question I want to ask is, what was the gap in knowledge that actually informed your study? I really don't see it. And the slides you presented to us in your result sessions, I was not carried along. I don't know for other members of the audience, because continuously it was results and discussions, and slides were not titled. So I didn't see what you were presenting. I was only seeing continuously results and discussions. For James from Kenya, I wanted to know, when was the policies developed? There were so many gains you attributed to the data. I don't know if those policies were developed as a result of the analysis you did, or they have been developed even before you did this analysis. If they were developed before you did the analysis, what is then the achievement, or what is the changes your analysis has brought? Like you said, how it has been used to take public health actions. I wanted to see that. To Tato from Lesotho, so I want to know, why did you exclude the less than 5 years population from your study? And yes, in your discussions, I didn't see the results discussed. For instance, you said high deficiency among the age group. Okay, so what was the reason? I wanted to see what was really the reason for most of the results you presented to us. And to the last presenter from, first one is a comment. You were not consistent with your figures. Yes, please, this one. We are reading to us that the first case detection was in 2022, but on the slide was 2020. So I don't know which one you actually wanted to tell us. And what was the knowledge gap, of course, again, from that actually informed your study to carry out the study, and which study design did you use? I was completely lost. So although you compare your findings with other findings like Turkey, but then what specifically, what public action led to your results in your country? I think I was interested to know.
Thank you. Thank you for the feedback. We will now ask our presenter for reactions. We will begin from the colleague from Zambia, and then we just go. So, Tato.
Thank you very much for the questions. I will start with the first one, where you want to know why there was a difference in terms of infections at the two university teaching hospitals, TB and COVID-19. Of course, you partly started answering the question that maybe it might be because of the low coinfection. But I would say mostly it might be as a result of the total number of the bidirectionally screen that were done in these facilities. The University of Zambia Teaching Hospital had done more tests when you compare with Lev Mwanawasa Medical University. So that might be the reason. The second person asked a number of questions. Number one, he wanted to get a clarification in terms of as to when was the first case detected in Zambia. I did it indicate that it was 18th March 2020. Maybe it was just a slip of the tongue that I mentioned 2022. There was again another question that what was the study design. I did mention that it was a descriptive cross-sectional study that used the secondary data from laboratory test records. In terms of the knowledge gap that was there, you might agree maybe with me that there was a continuous suggestion or a bias saying that people with TB are more likely to get COVID-19. And mostly people are thinking that maybe even those who are older, maybe 50 years and above, could get co-infection when they get when they are TB patients and they were likely to get COVID-19. So we were trying to answer that. We initially wanted to do that in all the high volume facilities in Zambia that we are doing bidirectional screening, but that was not done mostly because of the quality of data. We had headache even just to get and clean data from these two facilities. So you also asked us what next? We shared the results with, I did mention that with key persons from these facilities, directors of programs, HIV, TB, coordinators, and key staffs, what we found, and how would that help in terms of bidirectional screening, because it was noted that despite having the protocols and all the supplies and equipment in place, it was not being done. So we might not conclude that maybe the TB COVID infection, we might not infer that it was is low in Zambia because of these factors. So there was a step that was taken to just emphasize on the need to do the bidirectional screening. And again, another team took a step further to look at the possible factors that might be associated with the TB COVID-19 co-infection. Thank you.
Okay, thank you so much for the questions. So the first question was asked by Dr. Grace. So in terms of the cash transfers, you know very well that most of the drug-resistant patients, they are living in a dilapidated kind of life, and some of the drugs they are taking for 1 year. So it's a bit difficult for them to take drugs when their stomach is empty. So that is why the program came up with the approach or the strategy of giving them 6,000 every month, so that they can be able to one, to purchase food so that they can be able to take those drugs. Then two, also to sustain themselves in terms of if they have any other condition, they can be able to seek medical services which are not in relation to TB. So in terms of sustainability, today in the morning, you heard the guest speaker said that the government has come up with a UHC plan, and that UHC plan is going to incorporate everyone. So that is one of the sustainability that is going to come on board, so that even the drug-resistant patients that are going to be brought on board to that scheme, so that they can be able to be supported in terms of not incurring any catastrophic costs to buy other things, but to support themselves in their livelihoods. Then in terms of the raw numbers that were used for the drug-resistant trend, that is very true, because that is what the program uses. But again, the numbers are very few that you cannot be able to come up with the rates in terms of the trends. In terms of policy development, yeah, of course, this study was done after the policies have been developed. One of the objectives was to check whether the program is utilizing the drug-resistant data to come up with policies which are geared toward management of the drug-resistant patients. And I can say unequivocally that the program has utilized that data to come up with individualized formulation regimens, because not every patient will be given the routine regimen. Some of them, they resist to go to even to XDR. So through utilization of that data, they have been able to know that we have other patients who have extra strains that they need an individualized regimen formulation. Another thing, they have also been able to know that currently, initially, they used to see an upward trend of rifampicin resistance. But now, because of the utilization of data and optimizing the surveillance, they have realized that now isoniazid is coming on board. In fact, it is surpassing rifampicin resistance. So that means now they need to make sure that every patient who has been done the gene expert to identify rifampicin resistance is also done the LPA to identify this other regimen, so that they are not just given one drug until the second month. That's when they realize that this patient is also having a resistance to isoniazid. So those are some of the things that the data in the program has utilized to come up with interventions for the benefit of the patient. Thank you.
Thank you for your interesting questions. The first question was, there was similar opportunities and threats, but what makes the performance, the difference? One is good, the rest is not as expected, the question. So this is the problem. Once the TB patient starts the treatment, they either cured or completed. Just they finish their course of treatment. The problem faced is finding of the cases, the surveillance part. So in order to strengthen, in order to solve such problem as a country, since this fiscal year, 2023, TB is one among weekly reportable diseases. Number of new TB cases are among weekly reportable diseases. That means it is included in the surveillance system to early search the cases, TB cases. That is the point. Thank you for the question. And the second question, yeah, I present result and discussion simultaneously. I think sometimes it is good to understand more, to compare and contrast, and to suggest what was the problems in that way. After I uploaded the PowerPoint, just I prepared it independently, the result part independently and the discussion part independently. But what was the problem is difficult to update online. After just I already uploaded my PowerPoint, I wanted to edit and update it to differentiate the result part and the discussion part. It becomes impossible. Then what I do is now just I present simultaneously the discussion and the result. But there is one slide that summarizes the key finding of the study. Thank you for the questions.
Two questions were a bit similar because they were talking about why the under fives were not included in the study. I had mentioned earlier that because for under fives we use percentage and for adults we use absolute count. That was solely the reason why we chose to leave out the under fives. Another question was on the 34% for the Greg test. That was during the time of the study. There was a national crisis. The country was out of stock for the reagents for Greg, so that is why the test was performed that low. Another one was on whether severe immunodeficiency could also be advanced HIV disease. Yes, they are one and the same thing. There was a question on clinical information, why it was not in the clinical information in the recommendations, where I talked about the lab giving trainings to the health facilities that would address this issue of the missing clinical information. I think I have answered.
Okay, thank you. Thank you. Can we retire our presenters with a thank you applause? We also encourage you further engage them outside. If you still have doubts, you still need clarification, we can still continue the conversation. We'll now begin the second batch of presentation. So we'll have 4 more, like we said, and then we take the questions. So we'll now call on Peter, who will present to us HIV yield from a sister partner notification in Uganda.
Good evening, ladies and gentlemen. I am Peter Chris Kaunges, an advanced field epidemiology fellow with the Uganda Public Health Fellowship Program. I'll be presenting a study on HIV yield from assisted partner notification in Uganda, 2020 to 2022. As we collectively strive to control the HIV epidemic, the Joint United Nations Program on HIV/AIDS set the UNAIDS 95-95 targets for 2025 as follows. First, 95% of people who are living with HIV know their HIV status. This is crucial for timely access to treatment and care. Second, 95% of people who know their HIV status are on life-saving antiretroviral treatment. ART is essential for managing HIV and improving the health and well-being of individuals living with the virus. Third, 95% of people who are on treatment are virally suppressed. This is the critical goal of HIV treatment, as it not only improves the health of the individual, but also significantly reduces the risk of transmitting the virus to others. According to the 2022 report of the Uganda's population-based HIV impact assessment in 2021, 81% of adults living with HIV were aware of their status. This is below the UNAIDS target for the first 95. Therefore, there is a pronounced need for routine case finding to engage the population in HIV prevention and case finding efforts. HIV testing services are key to finding persons undiagnosed with HIV. In Uganda, HIV testing services are free and available at all public health facilities, from the lowest health facility at level 2 up to hospitals and special clinics. They are also available through community-based channels such as community health extension workers. However, this untargeted HIV testing, which is known as routine counseling and testing, leads to a less than 4% positivity rate, which represents an inefficient use of resources to find undiagnosed HIV positive persons. That's why, in addition to routine HIV testing, in 2017, the Ministry of Health optimized HIV testing services through the introduction of risk-based testing methods. Risk-based testing methods is an approach where HIV testing is focused on populations that are at an increased risk of HIV infection, such as being in sexual relationship with multiple concurrent partners. This maximizes the use of testing resources, as few tests are needed to identify one positive person. Index client testing method is one of the forms of risk-based testing. Index clients are individuals who are newly diagnosed with HIV or are already in HIV care but are not yet on ART, or are not virally suppressed, or have a new identified risk, like having a new sexual partner. Index client testing is an approach through which sexual partners, households and family members, including biological children of the index clients, are offered HIV testing services. We can see an example on the right. The index client is in the middle, has sexual and needle-sharing partners, and family members are offered HIV testing. Some of them are positive, shown in red, while others are negative, shown in blue. Some, shown in white, decline HIV testing. Assisted partner notification, or APN, is a subgroup of index client testing that only involves sexual partners of the client. In this presentation, I will focus on APN. The APN implementation process involves 5 steps. Step 1 involves identifying HIV positive clients, who we refer to as index clients. Step 2 involves interviewing index clients to enlist their sexual partners. Step 3 involves notifying sexual partners of their possible exposure or potential risk. Step 4 involves confidentially offering HIV counseling and testing services and linkage to care, treatment, and prevention. Finally, step 5 involves case closure. In 2015, APN was piloted in Chiboga district in central Uganda. The pilot demonstrated that partners were effectively notified and tested for HIV with a positivity rate of 38%. In 2017, Ministry of Health rolled out the program following the adoption of the 2016 World Health Organization guidelines on HIV self-testing and partner notification. In 2018, APN was progressively scaled up to 2,189 health facilities across all districts in Uganda, from level 3 health facilities up to hospital and special clinics. In 2020, the APN data was captured in the district health information system. HIV yield is the proportion of individuals tested for HIV that test HIV positive. Because APN targets partners at high risk of infection, the HIV yield from APN is expected to be higher than from routine HIV testing. At a national level, the yield is expected to range between 15 to 25%. In this study, we aim to describe the trends of HIV yield from APN among persons aged 15 years and above in Uganda from 2020 to 2022, and to describe the spatial distribution of HIV yield from APN partners in that age group. We performed descriptive analysis. The HIV yield was calculated as a proportion of total partners tested as a denominator, that tested HIV positive as a numerator. The HIV yield trends were tested for significance using Mann-Kendall test. Corporate maps for HIV yield were generated using quantum geographic information system. I will now present to you the study findings. This is a bar chart showing the national APN cascade during the study period. On the y-axis is the number of partners represented in blue bars, and on the x-axis is the APN cascade. A total of 461,274 partners were listed. Of those listed, 89% were notified. Of those notified, 81% were tested for HIV. Of those tested, 22% tested positive for HIV, which was the overall HIV yield. The line graph here shows the HIV yield from APN. On the y-axis is the HIV yield in percentage, and on the x-axis is the period from January 2020 to December 2022. The HIV yield was higher among female compared to male across the period. The national HIV yield, however, remained the same across the period, represented with a p-value that was not significant. These are corporate maps for regional HIV yield across the study period. The darker the shade, the higher the yield. More than 75% of the regions had the yield above 15%. West Nile region consistently had the lowest yield of less than 14%. In conclusion, APN identified people living with HIV more efficiently than routine HIV testing, with more than 1 in 5 persons tested, compared to fewer than 1 in 30 persons tested in routine HIV testing. However, there were still some gaps. 10% of partners who were enlisted were not notified, and more than a quarter of partners notified were not tested. There were also regional differences in HIV yield, with West Nile having the lowest HIV yield across the period. We recommended first intensifying APN across the country by enhancing the proportion of partners notified and tested. This could facilitate the identification of undiagnosed persons living with HIV. Second, we recommended exploring differences between the high yield and low yield regions to see if the differences are because of the implementation or due to other reasons. And finally, we recommended further study to investigate individual factors that influence the uptake of APN. We acknowledge these institutions. I thank you all.
Peter. We now call on the second presenter, Tualumba, who will present to us determinants of multi-drug resistant tuberculosis treatment outcomes among HIV co-infected patients in Tanzania, covering the period of 2017 to 2019.
Good evening. My name is Twilumba Liweuli. I'm a resident from Tanzania Field Epidemiology and Laboratory Training, and I'm here to present to you my study findings with the title of Determinants of Multi-Drug Resistant Tuberculosis Treatment Outcomes among the HIV co-infected patients in Tanzania from 2017 to 2019. So, this is my outline, which I'm going to take you through what has been done up to what was found. And starting from the background, as we know, Unfavorable outcomes among the MDR-TB HIV remain to be a major challenge globally, since the different data which from the studies worldwide which were done on MDR-TB HIV. Okay. Worldwide studies done on MDR-TB HIV co-infected patients reported varying proportions of these unfavorable treatment outcomes. As you can appreciate in the screen, we have until 44.3% of unfavorable in the treatment failure. And coming to sub-Saharan African, the situation even worse, since they're up to 51% proportions of these treatment, the unfavorable treatment outcome. And coming into Tanzania, proportions of these MDR-TB HIV unfavorable treatment outcomes by the year of 2019 in the TB report was 24, and this only included death and loss to follow-up. So possible reasons for these unfavorable treatment outcomes among the this group, the MDR-TB with the HIV co-infections has been mentioned to be not being on ART, malnutrition, having other comorbidities, drug adverse effects. And WHO has provided guidelines which give recommendations on how to deal with these individuals with co-infections, since it recommends early initiation of ART and MDR treatment as soon as they are diagnosed. And it has provided the optimal models on how to care for these patients with both HIV and MDR-TB. And it went further to decentralize the MDR-TB services to the regional level, as it has to, so as that can be available as the HIV services. And additionally, most of Tanzanian studies were done among MDR-TB, and little is known among this group with HIV co-infections. And also these studies which has been done, most of them were done at hospital setting. So this gave us the necessity of conducting this study, and we aimed at to assess the magnitude of determinants of treatment outcomes among the individuals with co-infections with MDR, TB, and HIV in Tanzania from 2017 and 19. So this was a retrospective cohort study, which was done at 31 regions of Tanzania. And we included the bacteriological confirmed MDR-TB who were HIV co-infected patients and were enrolled in the treatment from January 2017 to December 2019. And we excluded those with missing treatment outcomes, and those who were not recorded their deaths, since this is time to event analysis, the dates were very important. And our power was 99% after calculating using that formula, as you can appreciate in the screen. And our dependent variable was MDR-TB HIV co-infected treatment outcomes. And you had several independent variables, as you can appreciate: age, sex, comorbidities, up to treatment regime. So the data were extracted from the electronic TB and leprosy system in the form of Microsoft Excel. Was cleaned and analyzed using the Stata version 15, whereby we summarized our categorical variables using proportions, and our continuous variables like age, we used mean and standard deviation. We used bar graph to summarize the proportions of treatment outcomes, and also we had survival probabilities estimation using the Kaplan-Meier. And we went further and we plotted a curve of survival probabilities by stratifying using the nutrition status. And we conducted an extended Cox model and to determine the factors for MDR-TB HIV outcomes. And these factors which we had p-value of less than 0.05 were considered to be significant. And this work were proved had a full ethical clearance from MOHA's permission from Ministry of Health through National TB and Leprosy Program. And we didn't use names to maintain the confidentiality. We used unique ID. And these are my results. This is the bar graph showing proportions of treatment outcomes of MDR-TB HIV co-infected patients in Tanzania from 2017 to 2019. And the x-axis presents treatment outcomes, which was grouped up into favorable and unfavorable. And the y-axis proportions of these treatment outcomes. As you can appreciate, in the favorable outcomes, the cure proportions were 57.6, and in the unfavorable outcomes, we had around 23% of death, which is reasonable high. And survival probabilities during treatment of MDR-TB HIV patients from 2017 to 19. This is overall. As you can appreciate, they kept decreasing from 6 months of treatment up to 24 months. And we went further and we plotted a Kaplan-Meier curve showing survival probabilities during treatment of MDR-TB HIV patients in Tanzania. This was stratified by their nutrition status. The x-axis shows duration of MDR-TB HIV treatment treatment by months. As you can see, our follow-up period were up to 24 months. And the y-axis shows survival probabilities. And the blue line is the MDR-TB HIV patients who were malnourished, and the red line are those who were normal, had normal nutrition status. As you can appreciate, at 6 months, the probability of surviving for those MDR-TB HIV patients were 72%, but those who had normal were a bit higher at 95%. And this trend goes up to the 24 months of treatment. And this was significant since the log-rate p-test was less than 0.01. And as I said, we did extended Cox proportion hazard, and these are my results. We got nutrition status and adverse drug effects as the two factors that significantly affect the treatment outcomes. As you can appreciate, those patients who were MDR-TB HIV co-infected and were malnourished had around 3% higher hazard of developing unfavorable treatment outcome compared to those who had normal status of nutrition. And those patients with MDR-TB HIV co-infected who had at least one drug adverse effect also had one higher hazard of developing unfavorable treatment outcome. So our study recorded a higher unfavorable treatment outcome compared to other studies which were done in South Africa and Lesotho. And the reason for these differences could be explained due to differences in study design, probably since our study was the retrospective cohorts, but that of South Africa was cross-sectional. But also we had different participant characteristics. The South African participants were adolescents and ours were included all age groups, so this could explain the difference in the proportions. But also the overall survival probability were similar to the studies done in Zimbabwe, but were low compared to those studies done in Europe. And the reason could be, to this dismay, could be differences in HIV prevalences. As you can see, the Europe HIV prevalence is different with the African countries' HIV prevalences. And Those patients who were MDR, TB, HIV in our study had low survival probabilities, as we appreciated in the Kaplan-Meier, and this was similar to the studies, several studies done in Africa. And the possible reason could be due to severe suppression of immunity by both MDR, TB, HIV, and malnutrition. And also, malnutrition and adverse drug effects were potential factors that determines this unfavorable treatment outcome, and this was similar to the studies done in Africa, countries like South Africa, Ethiopia. And the reason also could be explained by severe suppression of immunity, which is done by malnutrition, but also those people who tend to have adverse drug side effects usually have non-adherence to the medications, and they normally tend to end up with unfavorable treatment outcome. And we concluded that we had high unfavorable treatment outcome and low treatment success rate, but also malnutrition patients had low survival probabilities, and malnutrition and adverse drug effects are factors for unfavorable treatment outcome. So we recommend Tanzania National TB Control Program to make more efforts in lowering these proportions on unfavorable treatment outcome among these MDR, TB, HIV co-infected, and hence they raise their chances of surviving during their treatment. But also, malnutrition and adverse drug effects should be potential factors in future intervention of MDR, TB, and HIV patients. But also, for those who are in the facilities, the case managers, we recommend them to early detection of fatal adverse drug effects to individuals with MDR, TB, and HIV, since this will help to quick intervention and help yield good treatment outcomes. I would like to thank the United States of Present Emergency Plan for AIDS, PEPFAR, through Center of Excellence in Health Monitoring Evaluation, University and the Center of Disease Control, CDC, for their support, technical and financial, for funding this study. And thank you for my supervisor, Dr. Ali, and my head of department, Dr. Mucho and Siande. Thank you.
Thank you, Twalomba, for the presentation. Just have
Twilumba.
Twilumba. Thank you. So we'll actually encourage the presenter to keep within the 10-minute limits. We really beg you, we press with time. And the next presentation will be on the determinants of viral load non-suppression among HIV-positive children and adolescents attending care and treatment clinics in Tabora region and Tanzania from January 2018 to April 2022. And we will be calling Ruth Makuvu for that presentation. Machovu. Muchovu. Thank you.
What? I'm using this. Good evening. Okay. My name is Ruthie Daniel Mchomvu. This evening I'll take through this presentation on the determinants of viral load non-suppression among HIV-positive children and adolescents attended HIV care and treatment clinic at Tabora region, Tanzania. By introduction, the United Nations Program on HIV and AIDS, UNAIDS, has set a motivated target aiming to control the HIV epidemic by 2030. The basic premises for this is to reduce the risk of transmission of HIV and to improve the well-being of the infected persons. So due to the scarcity of the information on the determinants of viral non-suppression among, it's not going. This one. Okay. Sorry. So the objective of this study was to determine the determinants of virulence suppression among HIV children and adolescents in Tabora region. The methods, the study design was a retrospective cohort study, which conducted in 7 councils in Tabora region, Tanzania. The study population was people living with HIV, with the age less than 20 years, who were registered between January 2018 and April 2022. And the other factor was that they were supposed to have they were supposed to be on ART for at least 6 months. This scheme is showing the data, how the data was obtained. As I mentioned, this was a retrospective cohort study. We abstracted the data from the CTC2 database from the respective councils, and after cleaning and observing on the inclusion and exclusion factors, we involved about 378 children and adolescents in the study analysis. The study analysis was using a Cox proportional hazard regression, and the hazard ratios were estimated as a degree of association between virulence suppression and the client's characteristics. And a p-value of 0.05, less than 0.05, was considered statistically significant. From the table, it showed the descriptive characteristics of the study participants. In this, it showed that the proportion was high between the clients with high baseline CD4 counts, also in the male sex and the like. Table 2 showed the analytical part, where bivariate multivariable analysis was done, where you can see there was the significance factor was ART adherence level, baseline CD4 counts, and current regimen line. Those 4 factors were significant on virulence suppression. We recommend that HIV control program administrators should carefully consider and evaluate children and adolescents with non-viral suppression before switching them to second line, as this was one of the determinants we saw. Also, HIV program administrators should adopt age-specific approaches and in decreasing virulence suppression. In conclusion, the HIV virulence suppression in this study was found to be high, which makes it less likely to achieve the 95 units targets they set. So intensive adherence support and counseling should be provided to children and adolescents with poor adherence, low baseline CD4 count, nevirapine, those who were on nevirapine and lopinavir-based regimen, and those who were on second-line regimen, so that to find a way in which to improve the viral suppression. Thank you.
Thank you, Ruth, for that presentation. We'll now take the final presentation for the section on the factors associated with HIV pre-exposure prophylaxis, uptake among female sex workers in Karongi Peri urban area, a cross-sectional study. This will be done by Gabriel Tuaka Rimana. I'm sorry. It will be done by Gabriel. His name's giving me some tough time today.
Good evening. Good evening. My name is Twagrimana Gabriel. I'm going to present my topic to treat factors associated with HIV pre-exposure prophylaxis uptake among female sex workers in the Karongi district peri-urban area, March 2021 to December 2021. Those are the outline, background. Yeah. PrEP is an additional preventive method using antiretroviral treatment for the person with free HIV to reduce the risk of getting HIV. Of getting HIV, and the research has shown that if they use it as prescribed by medical prescriber, it reduce the HIV about 9%. The study aimed to explore the factors associated with HIV PrEP uptake in the Karongi district. Specific a specific objective to determine socio-demographic characteristics in the Karongi district to determine a proportion of female sex workers who uptake HIV exposure prophylaxis in the Karongi district, to determine the factor associated with HIV pre-exposure prophylaxis uptake in the Karongi district. Is a cross-sectional study design that where we extract the data in the patient file, or where is a key population and the follow-up in the health facility from the 10 health facility out of 26. The proportion were calculated for describing the characteristics of female sex workers, and bivariate and multivariate analysis using logistic regression was used to measure the associated. Those to measure the association, the 95 confidence level and p-values than 0.05 considered as statistically significant, and ethical clearance has obtained from University of Rwanda. As the result, the characteristics of female sex workers were 15% were in the category of socio-economic category of the two. The socio-economic category is classed in 4 in Rwanda. 1 and 2 and low is low socioeconomic, and 3 is medium, and 4 is higher. Occupation, farmer are 63%, and mode of recruitment is healthcare provider. The proportion we found that is 53%. And factors associated with pharma were around time more likely uptake for HIV prophylaxis concerned to the self-employer, and those which with regular HIV and at least HIV-free months are around more likely uptake HIV pre-exposure prophylaxis, and those who recognize to have multiple sexual partners around 3 to 4 are 2.3 times more likely uptake of HIV pre-exposure prophylaxis. Those who have health insurance was 10.5 more likely uptake HIV pre-exposure prophylaxis, and those who had had before a HIV pre-exposure prophylaxis has around 5% time more likely uptake HIV pre-exposure prophylaxis, and those who use condom are around 6 times more likely uptake HIV pre-exposure prophylaxis. As a conclusion, these studies show that the low proportion of HIV pre-exposure prophylaxis uptake among female sex workers during its implementation in Karong district. The low proportion of HIV exposure prophylaxis should be improved by PrEP awareness among female sex workers and integration of HIV exposure prophylaxis service in different departments and health facilities, such as family planning and the outpatient consultation. Family sex workers who test regularly and those who have health insurance are more likely uptake HIV exposure prophylaxis. Recommendation: encourage female sex workers to get regular HIV testing and create awareness about HIV PrEP during its session of HIV testing. Target female sex workers with multiple sex workers for PrEP awareness and education program to promote health insurance coverage among female sex workers to increase access to HIV PrEP, pre-exposure prophylaxis. Promote the condom use also even if it's low coverage. Those are the actions to take. We shared this data with the stakeholders. Then our community and the clinician use it. The sensitization and the training has organized sensitization and the training for health workers, and one ONG who work in Karong, this has provided the goat, and some give the health insurance for these partners. So, thank you. Thank you.
Thank you, Daniel, for that presentation. And now is the time, and we will open the presentation for feedback. We encourage you, go straight to the point and ask your question, please. So just raise your hand if you have questions. Your question should be directed to the specific presenter. Yes. Any other person? It's just one? Okay, two. Do we have any question for this side? So apparently we'll be having two questions. Oh. Okay. Go ahead.
Hello. Thanks for the presenters for your wonderful presentations. I have a couple of questions to almost each of you. So the first presenter presented the HIV yield in Uganda. So my question is, how did HIV yield compare with the regional HIV prevalences? Do we see any association or not? My second question is to my Tanzanian colleague who presented about MDR, TB, and HIV coinfection. So when you talk about survival probability, what are you referring to? Surviving to the outcome of interest or surviving not to die? And my last question goes to my colleague from Rwanda. when did Rwanda roll out?
Thank you for very nice presentations, all of you. My question goes to my fellow from Rwanda. He said 33% of female sex workers were using PrEP, and he used odds ratio as his measure of association. Don't you think that will, may have overestimated your findings?
Thank you very much for the presentations. I would like to ask the lady who was doing MDR-TB. Hello? Can you hear me? Okay, so TB is already known to be a thinning disease. Hello? Okay, thank you. I was saying that TB is already known to be a thinning disease. And so when you say that malnutrition was found to be associated with poor outcomes, I wanted to know how you measured malnutrition among the patients in line of the fact that they had TB, because already it causes thinning. Thank you.
Feedback. We'll now take reactions from the presenter, beginning with Ruth.
Okay. Thank you for the questions. I'm going to respond to the first question which was asked by my fellow Tanzanian, which was, what do I mean by survival probabilities? What I meant is surviving to the event, the outcome of interest. And for the second question, which was from, I think, my neighbor from Uganda, yes? Yeah. She asked that, she said that MDR-TB already caused thinning. And how did I measure the malnutrition status, right? Okay. For a person to be having malnutrition, we normally rely on the BMI. So in the data, all of the patients had their BMI, and that's what I used as to categorize if this person is malnourished or not malnourished. And those who were less than 19 were considered as malnourished MDR-TB patient. I think I have answered your question.
Thank you, the audience, for the question raised. And specifically, you wanted to find out whether the HIV yield from APN had an association, no correlation a bit with the HIV prevalence. Yes, I agree with you. When we really did an observation of these findings, the regional HIV yield was quite flowing with the HIV prevalence. For example, the West Nile, which had consistently lower yield, less than 14%, also according to the With your report, it has consistently low HIV prevalence. Yeah, though we didn't want to stop at that and think that probably that's the reason, we need to do an extra mile to really study the process and know if there are other additional factors that could explain. But it did agree. Yeah, thank you.
Thank you for the question. I have around 3 questions to respond. The first one is when Rwanda has rolled out a PrEP. I go back, the WHO has recommended HIV PrEP in a HIV guideline as HIV prevention method in 2015 and 2016, and has implemented in Rwanda as a pilot site in 2019. And this piloting was based on hotspot area, especially in Kigali.